You and
Good morning, everyone. Sorry about the slightly late start, a few technical issues there. Happy New Year to those of you I haven't seen, although mid-January is probably a bit late to be saying Happy New Year, but never mind. Happy New Year anyway. Welcome to the Kennet Room at County Hall for the January meeting of Health Select Committee. We'll move straight on to item 1, apologies. Stuart, I believe we have 1 or 2 apologies this morning.
Thank you, Chair. Yes, we have apologies from Councillor Cape, Councillor Champion. Mike Sankey sends his apologies because he can't be at the meeting, but he's joining us online. And also Councillor Bowler sent apologies, and Councillor Carbin is substituting for him.
Great. Thank you, Stuart. We'll move straight on then to item number 2, which is the minutes of the previous meeting. Is the committee happy for me to move that the minutes from the meeting held on the 1st of November 2022 as a true record? Seconder, thank you, Howard. Any objections to that? None? Great. In which case that's moved, and we shall move on to item number 3, declarations of interest. Are there any declarations of disclosable interests or dispensations as granted by the Standards Committee? None, in which case we'll move on to item number 4, Chair's announcements. Just a couple of announcements this morning. An informal committee meeting to review the Council's budget. So the Council's proposed budget for 22-23 and its medium-term financial strategy 22-23 to 24-25 has now been published, and a link has been circulated to all members. The process for scrutinising and approving the budget will be the same as last year, as follows. So each select committee will hold a short, informal online meeting to discuss the parts of the budget relevant to its remit and to agree the questions the committee chair should ask when the budget is considered by the Overview and Scrutiny Management Committee at their meeting on the 24th of January. So this committee's online budget meeting is scheduled for tomorrow, 2 p.m, tomorrow Thursday, and that will take place on Teams. Most of the services that this committee focuses on fall within the Council's People Directorate, and that directorate accounts for more than half of the Council's total budget. It's therefore vital that those proposals and their implications are scrutinised robustly. Could I therefore ask all of you to take a look at the budget report, consider what questions or points you would like me to raise at Management Committee, and to please try to attend the committee discussion of the budget tomorrow at 2 o'clock. If you aren't able to attend tomorrow, please do send me and the scrutiny team your questions by email instead. Thank you. So that's it for announcements. We'll move on to item number 5, which is public participation. I'm not aware of any today. Is that the case? Thanks, Stuart. In which case, we'll move on to item number 6 on the agenda, and this is the update on primary care workforce challenges. In September, you may recall that the Director of Primary Care at the Integrated Care Board outlined workforce pressures being experienced in primary care. It was agreed at the time to schedule in an update to enable the committee to better understand the workforce challenges across the primary care system. And I'm delighted that we're joined this morning remotely, I believe, by Joe Cullen, the Director of Primary Care, and also Fiona Slevin-Brown, Director of Place Wiltshire from the Integrated Care Board, who will outline the current workforce challenges in Wiltshire primary care provision. So I'll hand over to Joe, I believe, who's waiting online, who will take us through the presentation. Thank you, Joe.
Thank you, and good morning, everyone. So yes, I'm Joe Cullen. I'm the Director of Primary Care for the Integrated Care Board across Spain, Swindon and Wiltshire. I've got a number of slides here. I wasn't going to go through all of the detail on all of them. I'm happy to obviously circulate them and share them and take any questions. If we can move on to the second slide, please. Just as an overview, I think no one would be surprised to hear and be aware of the increased demand across all of our GP practices across the whole system over the last couple of years really, but the last number of months have been pretty challenging across our GP practices. We've had really high levels, particularly from sort of November, December, around the same day demand being exacerbated by the increase in the respiratory illnesses and the presentation, particularly of children around the strep A illnesses, which were very much in the media before Christmas. what we have done locally is very much encourage our GP practices to focus on that same day urgent demand, which has been really focused and brought forward rather than some of the more routine work, which again has to balance out. We've known this over the last couple of years. It's a balancing act really between working through the sort of the routine work as well as the demand that's been faced on a daily basis. So we have encouraged all of our practices across Wiltshire to be repurposing and using resources as in hours and time and the skill mix that they've got based on the clinical judgment. So that really has focused on our workforce challenges, whether that's GPs, nurses, pharmacists, or some of the non-clinical support staff that we've got in practices. We had at that time, as with the general public, high levels of staff sickness, and we know we have got significant vacancies in some of our practices for some of the roles, and I'll come on to that in a minute. We also know, and we've reported to the committee a number of times around the impact of the vaccination programme. Sort of 60–70% of that was being delivered by our primary care and our primary care network colleagues across Wiltshire. And of course, the support when we have the whole system challenges and crisis, it is a whole system response, and name there around the responses that we know about, the pressures and the challenges across our ambulance and our ambulance responses, the pressures in hospitals, community, mental health, and social care. So all of that has an impact on our workload and demand on our GP practices. The next couple of slides we've got in a minute is around that they're southwest wide summaries, but it just was really to assure the committee that BSW and Wiltshire obviously within that are in a relatively good place as according across the southwest for all of our roles, but obviously it shows the level of scrutiny and assurance that we are working on, reporting both to NHS England and our ICB board. So you'll see there BSW, Bain, Swindon and Wiltshire on the left-hand side. Actually, there's a number of areas with the ARS is the additional roles that come through with the practices that work together as primary care networks. We're doing some work there around that recruitment. Each of the primary care networks, there's a national list of staff that they can recruit to and are funded through that funding. And again, we're constantly on that with the primary care networks about what posts they're recruiting. Those include paramedics, social prescribers, a whole range of staff that support the GP in delivering a skill mix to meet the demand. And there's one practice there we're working with around some of the data quality. But compared to other areas in the southwest, we feel we're in a pretty good place. We're obviously not complacent about this, but across Bain, Swindon and Wiltshire, where there are no real major concerns as there are in some of the other areas. And I think I just wanted to, the next slide, we just break it down by those roles. So the next roles is around the doctors in general practice, which obviously is for our public assurance as well. Again, we are green, as in no concerns from NHS England. You'll see there that our rate per 10,000 weighted population for BSW is 6.4. So we're sort of third in the list, really. So again, some of our other areas across Bristol and Cornwall are in the same position, but there's challenges across some of our other big county areas in the southwest. Conscious there's a lot of detail on that slide, but I just wanted to show the committee that this is the position and this is the reports that we do built up from each of our areas across the southwest. Similar position for the next slide around our general practice nurses. Again, 3.9 per 10,000 weighted population compared to some of the other areas. We're actually sort of top of the league in the southwest for our general practice nurses, which is really good news because that's obviously supporting our workforce team. Sometimes that does go against us when obviously the national focus is very much around appointments with GPs. It doesn't always pick up the fact that actually we have got a really good work stream, a strong workforce of general practice nurses delivering the care as well. So again, good news. We work very closely with our practices on this, but it's very good news as far as our workforce there, and and our returns through NHS England. And then the last slide from a sort of Southwest point of view is very much about some of those other roles, which are direct patient care roles. They pick up a number of roles around some of our healthcare assistants and some of the roles supporting direct patient care rather than being a doctor or a nurse. And again, we're green on that as far as 7.1 per 10,000 patients. So again, not quite the top, but we're in the higher range across the Southwest. So good news from a Southwest point of view, doesn't make anybody, as I say, complacent, and we're focusing on that all the time around making sure that the practices are working with their skill mix. So really sort of trying to support the GPs to see who they need to see and picking up the care alongside that as direct patient care. So moving into some of the Wiltshire specifics, I know at the last committee we were focused and were asked a question about vacancies. So this was a snapshot really around sort of the last the full year of vacancies. This just shows the number of different roles that are being advertised across Wiltshire. Obviously, this is there's maybe some double counting, and that not all the vacancies are advertised on here. But we have a BSW website that, again, we encourage all the practices to use so that we can see that and we can give the encouragement around attracting people, particularly into Wiltshire. And you'll see the numbers there. So 40 GP vacancies, a lot of admin and reception and non-clinical support roles. I think we've seen that since pandemic days about some of the pressure that those front desk staff are facing. And I think that's a real concern. We've had a number of practices that have had resilience issues, not because of their clinical staff, but because of their admin and reception. That impacts on obviously things like answering the phone and doing all of the work behind the scenes. So they are really under pressure, those roles. And I think we probably would all be aware of other roles that are probably paid equivalent that are less stressful than some of those roles. So that's a constant issue around recruiting into those staff. I think again the number of roles there, we've got an issue again with some of our pharmacies, and again some of the pharmacists have moved into primary care, and again that's a sort of constant moving thing that we don't want to destabilize other services by recruiting and pulling people into general practice. So this is, like I say, just a snapshot, but again a lot of work goes on behind the scenes here around absolutely supporting our other providers like our community pharmacies. Obviously, paramedics are a role that now can be recruited into general practice, but it does no one any favours if we're recruiting them from our ambulance trust, and likewise our mental health practitioners. So I think it's quite significant. That's the sort of the worrying figures here around the number of vacancies we've got. And I don't think we've ever had such an issue really with our GP recruitment into Wiltshire over the years that I've been working. We've normally had numbers of people coming in going for those jobs, but some of our practices are constantly out for recruitment, and it is about the GPs coming forward across the country really recruiting. I mean, most areas are recruiting, so yeah, that just shows a sort of a snapshot there really. I think for on the next slide around recruitment itself, we know there's difficulties recruiting to GPs around where we are in Wiltshire compared to some of the other areas, especially some of the younger GPs coming out of their training, more attracted to some of the city areas where they've been doing their training and having their sort of communities of GPs. There is definitely something around recruiting GPs into some of those partner roles and everything that brings with it around the surgery building, the buying into that partnership role, and again lots of national debate about the partnership model really of general practice. All of this really has resulted in really high locum costs coming. We're talking maybe £1,000, £1,500 a day in some cases for GPs, and they come with their conditions of whether they'll do home visits, whether they'll do mental health and maternity issues. So really struggling with that. And of course, that's the sort of market that really is hard to deflate once it's got to that position. And again, we see that with all of the different services for out of hours, some of the urgent treatment centres, all of the services needing GP, it's driving up those locum costs. And again, that is on the national agenda as well, as to whether anything can be done really collectively. It's not specifically a local issue, but when practices are very desperate, they often go through agencies or bring people in from other parts of the country. Also, we know since the pandemic, really, we've really developed the side of remote GPs working, and again, they can be in other places in the country. So that again, different conditions, trying to get somebody to come in and do actually some face-to-face work in a local surgery is a constant struggle, and our practices are constantly battling with that one. Again, similar with the clinical pharmacist roles, they're very, again, a few years back, there was a lot of pharmacists around that we could bring into different services. But again, some of those have been recruited into general practice, but our clinical high street community pharmacies are then struggling, and then they need to rely on locums as well. So again, they're a group, and again, our mental health practitioners with Avon and Wiltshire Partnership Scheme. Again, there's a national specification for all these roles that we have to keep within those specifications. So again, they are a precious commodity, bringing our mental health practitioners in that can support with that face-to-face care. We know across Wiltshire, again, this isn't a new issue, but we have got an ageing workforce across our roles. And again, we're doing a lot of work into that around retention of our staff and supporting conditions for people carrying on working, particularly after the last couple of years, what they've gone through. But again, that is a concern, and we're talking, managers and clinicians in all roles, really, that workforce. And that is quite a specific Wiltshire issue there. And again, there's pressure with all these new roles coming in to support the GPs. There's a big commitment on the GPs to provide that supervision and mentoring time for those new staff that, again, takes them out of patient care. But it's important, obviously, to do that when they're bringing in these new teams of people. I mean, it's sort of a primary care network of about 30,000. Somewhere like Bradford and Avon and Melksham, they've probably got 35 staff working across the PCN now. So, of course, some of those are clinical, some of them are not. So that commitment for supervision and mentoring is actually essential. And then with that comes the state's pressures about accommodating new staff. The whole point is we're trying to build integrated teams. And so a big part of that is that they're based together and working. That works well in some areas, but with others, with more rural practices, that is always a challenge as well, to make sure that we've got that estate accommodation, that people can work together as a team. So specifically with the GPs, on the next slide, we are seeing this across the Southwest. There is that overall decrease in GPs training and GP partners. We are seeing now we have got more, the balance has moved away from more partners in practices, but we have got salary doctors, we've got doctors that are coming back from doing other things, we've got doctors in rotational posts. But again, we're constantly monitoring that around that shift between what's a partner and different roles of GPs into providing primary care. As we've mentioned before, we have got that Southwest maintaining that highest level of full-time equivalence. But again, that's we're not far away from that moving downwards. What we did introduce a year ago was a flexible pool, which is basically our sort of way of using. We've got a partner, Lantham, which is a digital staffing platform, basically an agency, but it's very specific for Bain, Swindon and Wiltshire. And as of this week, we've got 145 staff signed up on that, which is a really good achievement, and 102 of those are GPs. So this is where practices can put out shifts that they need to be filled, and the staff, out of those 145 staff, they can sign up for those shifts. They've all gone through the recruitment and the processing to be signed off, and 75% of our practices across BSW are signed up to using that. So we're trying to have a local solution to some of this to support the practices, rather than going out to some of the national agencies and locum fees. And again, there's a sort of a project and staff and team behind that are trying to make it as straightforward and as simple as possible. And like I say, as far as an assurance point of view, NHS England have rated us green on this. But like I say, we're not resting on any laurels because we know there's still a whole lot of work to do to make sure that the position doesn't worsen, and we really are focused on each individual practice and their particular conditions. For the nurses, again, we've got, said before, the Southwest, we've got a positive change for nurses in general practice. And again, moved on a slide, please. The PCNs are now able to recruit trainee nursing associates. We've got a big program going on around apprenticeships and nursing associates using this funding from the additional roles reimbursement. So again, that's been successful that we're bringing those staff in. Really big development program going on, and that is working really well. And again, brings in the career pathways, and it looks to support growing our own workforce, which again we've attracted a number of really good case studies. Again, really happy to bring that back to the committee for some case studies for all of these elements, really. But I think the challenge with workforce, we know it's not just about the recruitment, it's about retaining, it's about training, and it's about providing that career pathway. So again, from an NH England point of view, we're on the green rating, but a lot of work going on behind the scenes. Next slide again, I think probably just repeating some of this, but the patient direct care roles, again, we're on track around that recruitment for those roles. And as you can see, we've got the additional roles is through that national funding for the PCN, over 400 staff now in post, and 200 of those are in Wiltshire. So the Wiltshire practices and the PCNs have been really successful in recruiting and bringing that in locally. The next slide specifically about those additional roles. So we have, the primary care networks have to put a plan in against each of those roles, which has to be signed off. It's through the sort of the national NHS England rather than the ICB. But again, they put the plan in. They then have to deliver that and recruit those staff. And again, that's being very closely monitored on a sort of a monthly basis. And any of the funding, it's not sitting with the ICB, it's sitting nationally with NHS England. Anything that's not allocated or a PCN hasn't drawn down its allocation, we are making sure that we're using all of that funding across and sharing it across the other areas. 2 roles were brought in from October with some of the national changes. Again, a digital and transformation lead, which some of the sort of the managers of the PCNs doing that transformation, really linking and driving the integrated teams, and a general practice assistant, which again, we've had some of those roles, similar roles across Wiltshire previously, but this again is very closely monitored, the roles and the support that again, our GPs are doing what they're trained to do rather than some of the other roles, some of the other tasks and roles. So all of that has been successful, and again can bring back some of the case studies if people are interested and provide more local data on that. So sitting behind all of this on the next slide, please, is our training hub, which is part of our integrated care board. And again, working very much hand in hand with them around meetings with our practice managers and our PCN managers, focusing on the areas that you would expect really with workforce challenges around recruitment initiatives, apprenticeships and placements, different schemes and different lines around retaining the staff that we have got, and bringing in as many people as possible. And some of those people that are coming in through that flexible pool are actually staying, which is a really good outcome, that they are coming in and seeing the practices and working there, and then actually picking up some of the more substantive roles. A real focus on upskilling to support our workforce demands, particularly the pressures and things like the respiratory and paediatric demand. All the time, it's about the upskilling, the competency of the staff to deliver that, and a real focus on the new roles coming in with real clinical and professional leadership. So that was the end of the slides we've got. I hope that gives assurance to the Health Select Committee that we're very much focused on the workforce supporting primary care to deliver. Really happy to take questions and really happy to provide any more local data and case studies. So thank you.
Thank you very much, Joe, for that very detailed report. And, good to see that there are some positives in there in terms of staffing levels, etc. Fiona, did you have anything you wanted to add to that, or shall we go? Well, in which case we'll go straight to questions from committee. Councillor Pauline Church.
Thank you very much. And thank you, Joe, for the presentation. I just have one question around attrition. It's good to see that there's some increased FTE across the board. The numbers are up across all sort of employment classifications, but the vacancy rate is also high. So I'd like to understand if this is due to increased staff attrition or new posts. Thank you.
Thank you. I think it's a combination of both. I mean, I think, as we've said, we've got an ageing workforce. We've had, I can't remember the exact details, but a number of our more senior GPs have been retiring, as well as our nurses and managers. So I think it's a combination of both. People are moving around, and I think it's just a sort of complex picture. I think it is, let's say, it's a combination of a number of things.
Thanks, Joe. Any further questions? Councillor King?
Morning, Joe.
Morning.
And thank you very much for your presentation, which is a bit far away from me, so I can see it in great detail. I got a very similar question to Pauline, really. I guess that each PCN is contracted to deliver a number of hours of clinical time each week, and that includes from doctors through the rest. And I just wonder, how many hours are not being delivered? Do we know that by PCN?
It's sort of not quite that equation, really. So a GP contract covers, they have to be open between 8 and 6:30. They're not contracted to provide in that a level of appointment, for instance. Each PCN then has to provide enhanced access, which is the 6:30 till 8 in the evenings and Saturdays, and that is the one that's monitored on hours per 1,000 patients. So they are delivering that, and they're delivering it in a range of ways. So some of that might be face-to-face, some of it might be remote or by phone consultation, some of it might be by the staff members. So I think where we've got some individual practices that are really struggling maybe to recruit GPs, they are upping it on the number of nurses or pharmacists or other roles that are providing that. So it's not quite the equation that we don't think they're not delivering the hours. It's the service and the type of service that they're delivering, that we're constantly having that conversation, that they've got enough of, say, clinical staff compared to the non-clinical staff or the GPs as opposed to the assistants. So we've definitely got some practices that are more challenged than others. Some are far more successful at recruiting and keeping staff. So again, a lot of that sharing across we're really trying to work with. And like for your area, we've got 2 practices in one PCN across 2 towns. So again, each of the PCNs is slightly different. I don't know if that's answered the question really, Gordon, but it isn't really a close, we know there's so many hours they're not delivering. It's about sort of the outcome across that contracted hours.
I guess it might be a difficult question, but when you've got a practice, say, of 10 doctors and the majority of them working part-time hours, you wonder how all those contracted hours are being delivered.
Yeah, and again, there's no stipulation around the number of. I mean, we have got a lot of some of the practices I can think of that are more doctored than anything else, and others that have got less doctors but more of the other roles. So again, we don't sit here thinking, oh, you've got 8 till 6:30. Each of those hours have got to be filled. It's about the appointment time, and again, we monitor the appointments that have been delivered by GPs and then the nurses and then other staff. So we've definitely got the report. So alongside this goes the access element, and again that was published nationally in about November time. sometimes, like I said before, that it's very focused nationally. The political drive is on face-to-face appointments with GPs. And again, if we've learned anything over the last couple of years, some of that can be dealt with more efficiently remotely. Some of it can be dealt with by a pharmacist or a physio or a mental health worker rather than a GP. So again, we have got that extra information that proves or shows the outcomes in as far as the appointment times. So we can definitely share that, and that's broken down by practice level. So we can split that if you're interested in seeing a particular area or a particular PCM.
That'd be interesting to see, but thank you very much.
Thank you, Gordon.
Any further questions? Pip?
Really, just a comment. Horrified at some of the statistics, and yet NHS England rated BSW green, and they're doing better than most. I find that very sad, because my comment would be, heaven help the rest of the areas, because this is, whilst we are good as far as BSW is concerned, what on earth is happening in all the other areas? And overall, I know we're only interested in Wiltshire, and being parochial again, Warminster is a very sad case, because we do have a lot of shortages, closed surgeries, and one pharmacy that has to close through lack of staff. And I just wonder how this fits into the overall general picture that we hear of all these stories on the in the papers and on the news, especially in view of the fact that now we're in also strike action by nurses and ambulance drivers. Is it all malicious gossip, or are you seriously in quite a bad place, even though you're better than most?
I wouldn't say we're in a bad place. I think we're in a pretty fragile place as far as all of the things we've talked about retaining the staff we've got, the aging workforce, the pressures and demands of the job. I mean, I'm really happy to provide the data for the Westbury Warminster PCN and maybe set up a separate call outside of this, because I think they could assure you on what they're trying to do. I don't think any of them are feeling comfortable or complacent and thinking we're fine and we, you know, all it takes is for one person then either to leave or to go off sick or to have an issue. So it is a pretty fragile situation. I don't think it's a bad place. I don't think it's malicious position, but I do think it's very, we can provide those data, and like you say, the Southwest, then BSW, but actually people want the information at a very local level. So again, I'm very happy outside of this to share that detail for Westbury Warminster. We know we've had challenges at both of those practices with a number of staff leaving and changing. But I'm really happy to set up a conversation with them to come and sort of, you know, share that level of detail and what they really think. I don't want to be sitting here thinking we're just providing data and hiding behind it. We can really talk about some of the things that they're trying to do to attract staff, to keep staff, and manage the demand that they're facing.
Thank you. That really was a very honest answer, and I think fragile is probably the best word. And I'm sure Gordon would join with me and say we would very much appreciate some statistics for Westbury and Warminster. Thank you.
Yeah, we can do that, and we can bring in the, you know, representatives for both practices and the PCN to do that with you both.
Thanks, Joe. Any further questions from the committee? No. Joe, I just had a very quick question on one of the statistics was the challenges with reception staff in particular, and retaining staff because of the pressures they face. I'm aware of a practice that had an issue with a phone system. It had got itself into a contract that it couldn't get itself out of with a substandard phone system, which was putting extreme pressure on the reception staff to the point that the level of abuse they were receiving meant that there was just no attraction in staying in the post. Is this something that's quite common across the county? And is there anything that the ICB can do to support practices not to get into contracts with substandard systems?
Yes, that's a really live example, and we've got a number of practices that do that. Some of the phone systems that, again, the practices sort themselves out with what they buy in as far as the contracts and the service that they're receiving. Again, with the volumes of calls, some of us those phone systems are just not fit for purpose, and I probably can think of the practice you're talking about. There is helping as far as now there is funding they have to obviously buy themselves out of those contracts, and that sometimes prevents them doing it. But now there is funding available to support practices with those exit costs to then bring in a more fit for purpose and updated phone system that can support with the phone access. So we are aware there's probably a handful at any one time that are going through that exact scenario. And again, the result of that absolutely is really, staff that are thinking there's other roles that I could get paid this exactly the same rate of pay without this level of stress of having to be the one at the front line. So we're working with a number of practices specifically around their admin and reception teams, particularly as that burnout from the last couple of years. But there is definitely now that has been recognised not just across Wiltshire and locally, but across the country, that is a real problem, that then they have to pay money to get out of that contract to bring in a new one. And there's offers around sort of cloud-based telephony and all sorts of things that open up the number of lines that come in. So yeah, that's a very specific thing that has been picked up, and there is a sort of solution for that.
Good. Well, it's good to hear that it's an issue that's on the radar and there are solutions in place. I wonder if there's any scope, it's probably more of a national question, for the NHS to have a sort of database of preferred or recommended systems that practices should use.
Yeah, there's a framework of those. I'd say some of them are sort of the cloud-based. Who has to be the expert in any of this, but the cloud-based telephony. I mean, again, some of those open up the number of lines, but it still needs somebody at the other end of the line to be answering it and sorting that patient's request out.
Sure.
But it's definitely eased it. So, and again, a number of the areas are then linking up the practices to the same phone system, which is another obvious one, isn't it? That for resilience issues and for business continuity plans, that phone can be answered in a different place. Patient still has the same number and access, but again, that helps with some of our resilience, and some of our areas are moving into that place as well. But there is definitely a framework of preferred providers of phone systems.
Good. Okay. Any further questions from anyone? Joe, sorry, apology. I've got one further question, and again, it's probably slightly more of a national question, but just in terms of freeing up those valuable GP appointments, I just was interested to understand what kind of work is happening, and again, it's probably a national thing, in terms of things like repeat prescriptions. Does a patient really need to have to see a GP and use up a 15-minute precious appointment just to get a very straightforward repeat prescription? Is there any move to maybe enable pharmacists to be able to do that, or?
Yeah, and again, that's probably a whole. I mean, maybe Johnny, we can bring that back to another meeting, because there's a whole load of work around that. We've got a prescribing ordering direct service that sits with the ICB that covers probably a third of our practices across Wiltshire. So again, patients phone that system. It's people are sitting behind the scenes outside of the practice, but can manage all the repeat prescriptions. I think all of our practices have got clinical pharmacists in, which keep tabs on all of that. So there definitely is that whole piece about medication queries, repeat medication. Absolutely, most people for those situations do not need to see a GP. And our community pharmacists, a lot of work is being done. We've now got a clinical lead for community pharmacists that sit within the ICB that are really supporting that around electronic prescription services, so and then delivery. So really, it's very much quite an efficient service.
Okay.
But it would be good to come back and talk about pharmacies, because actually, again, we are being delegated pharmacy, dental, and Opton services from April, as well as an ICB. So some of us are old enough to remember when we did that as a primary care, a PCT. So it's coming back around, but I think the Health Select Committee would be really interested in knowing some of those aspects, particularly dental. And again, access to dental, the inequalities piece, the improving oral health, and our community pharmacies. So again, you know, we can come back at a later stage, either about particularly the repeat prescriptions, but equally what's coming from April.
Great. Yeah, no, we very much welcome that. Thank you, Joe. Great. I think that's it then, unless there's any further questions from anyone. No. Well, Joe, thank you very much for the detailed presentation and for answering those questions as well so robustly. So that is appreciated. I'll move a resolution that we note the detailed presentation from the BSW Integrated Care Board on the workforce challenges being experienced in primary care in Wiltshire. To note that while Wiltshire is in a fairly good position relative to other areas in the South West region, there are still significant challenges in the county's primary care workforce. And to receive a further item on work to expand the role of pharmacists, including prescribing medication. Could I have a seconder for that? Pip, thank you. Any objections? Okay, in which case that resolution's moved. Thanks again, Joe, and thanks Fiona as well for being with us this morning. We'll move on then to item number 7 on the agenda, which is an update on maternity transformation. So Lucy Baker, who's the Director of Planning and Transformational Programmes, is joining us remotely to provide us with an update on the transformation of local maternity services. The need for a redesign of services was highlighted in January 2020, and this committee at the time undertook some scrutiny, I believe, on that. It was before my time on the committee, but resolved to receive updates on the implementation of the programme. So we're delighted Lucy's able to join us today to provide that update. So I'll hand over to Lucy to run through the presentation, and then we'll open up to the committee for questions. Thank you, Lucy. Over to you.
Hi everyone, thank you, Chair. I'm so sorry I can't be in the room with you today. It's lovely to see some of you, and I know some of you went on the journey with us. So hello to Gordon and others who played a huge part in the work we had to do together. So I'm here today also wearing my hat as Senior Responsible Officer for the local maternity and neonatal system. Got a little bit of an update just to talk about maternity, and then we're going to come on to what's changed since we did that programme together. So next slide, please. So just a little bit of a reminder about what the local maternity and neonatal system is, the LMNS, you might recognise that acronym. It's about us working together, and really importantly at the heart of the LMNS are our mums, dads and families, and listening and hearing their voices. It's multi-agency, multi-professional. It includes a real range of people, health visitors, public health, our midwifery teams, obstetricians, and we work together to form what is now the formal maternity arm as part of the Integrated Care Board. So the local maternity neonatal system has been given more autonomy and more responsibility as we formed into an Integrated Care Board. And just a reminder about our co-created vision, which is that all women have a safe and positive birth and maternity experience, and are really importantly prepared to approach parenting with confidence. Next slide, please. So we just wanted to give you a little bit of context about our mums in Bain, Swindon and Wiltshire. So 2021, there were 10,356 babies born. What we're seeing is COVID hasn't increased that. So we're actually below the predicted numbers of babies we would expect to be seen born. And there's a number of reasons for that. COVID, the financial climate, and we're monitoring that really carefully. One of the other things that's been a real issue in the past is our rate of teenage pregnancies, and we're actually now below the UK national average. It's really important we monitor this because we know our younger mums do have a higher risk of challenges in pregnancy. The babies have a higher risk of poorer outcomes as babies in terms of neonatal outcomes, but also in life. And this links to ensuring that our babies have the best start in life. And some of the excellent work that's been happening in Wiltshire around baby steps and our parenting classes, which are targeted at in our areas of more deprivation to really support mums and babies. Next slide, please. This is just a slide that talks about some information, some population information. I don't intend to go for it in a lot of detail, but it's there for information. But if we go on to the next slide, it just breaks some of that down into a little bit more detail. So we know that we have in our footprint fewer babies from ethnic minority groups born across BSW. Great Western has the highest rate. Our stillbirth rate, that's an old figure because there's a real lag on the data, but even our recent data shows that our stillbirth rate is below the national average. We know that we need to focus on our Black and Black British ethnicity mums because they're at a higher risk of stillbirth rates. And we did a lot of work with our Maternity Voice Partnership around campaigns in local communities about what mums can do during pregnancy to reduce that risk. Next slide, please. So deprivation is a really important marker including preconceptual support and care. So in BSW, it's actually Swindon that has the highest proportion of births, but we do keep a really close eye within Wiltshire across RUH and SFT in particular around that support offer for our mums from more deprived communities. And that includes making sure that midwives are out in those communities working with health visitors to provide a wraparound support offer. Next slide, please. One of the other areas that you may be aware we've talked to you about before is around smoking in pregnancy. This is massively reduced, which is excellent news, but we continue to need to tackle this. Within Wiltshire, 1 in 10 of our mums smoke in pregnancy. The majority of those are under 25, with no mums over the age of 45 smoking during pregnancy. We were very fortunate to receive some additional funding. So we have dedicated midwives who support smoking cessation. And we've been working with the University of Bath on a pilot to prescribe e-cigarettes to mums and partners to reduce smoking in the household. And that has had a really positive impact in terms of smoking cessation, but also those family units not continuing to smoke when their baby is very young. The other area that's really important with a lot of focus is around preterm births and just understanding our rate and that national target that we need to reduce the number of babies that are born early. And I'll come on to describe what we're doing about that. Next slide, please. Some of you will recognise this. This was the journey we went on together in terms of our transformation roadmap. And as the chair described, we actually started this journey in 2018. It was a 2-year programme. Real collaboration, most importantly, to listen to what mums and families wanted around pregnancy, and in particular, where and when they gave birth. Next slide. So there were some service redesign proposals that came through all the governance, and these were the outcomes, just to remind everybody. We did reduce the number of freestanding midwifery units we had in our footprint that were not being well used, because mums were choosing to go to an acute hospital to have their baby. We wanted to ensure that we broadened our antenatal and postnatal care, so the care that mums have before and after they have their baby, to make it more local with a hub model with teams working together. We wanted to create 2 new alongside midwifery units, and it was really clear that this is what mums were asking for. We already had an excellent facility at Great Western, but particularly in Wiltshire and particularly in the south of Wiltshire, there was no access to this facility. And alongside midwifery unit is where a mum can give birth in a low risk environment with a midwife leading the process. It's very demedicalised, and it's an option for women who don't quite want a home birth, but they want something with lower interventions. Our acute obstetric services would continue in our 3 sites, namely Bath, Swindon and down in Salisbury, and we would work hard to improve and promote home birth for those women who chose that option. The other thing that we wanted to do was to really ensure that postnatal support, including breastfeeding support, was being provided close or in a woman's home, rather than what was a very historic model where mums would stay in a community hospital bed after they had their baby. So that's what we said we were going to do. What did we actually do? Next slide, please. So I'm delighted to report that the new Salisbury alongside midwifery unit has opened. It's beautiful. The mums love it. There are water pools there. What's really interesting is we have seen in particular from the Warminster area, mums choosing to go to this facility for a low risk birth rather than the acute unit at the RUH, and we've had great feedback. The opening was delayed due to COVID, and we'd like to extend to any members of the committee, particularly those that were heavily involved. If you want to come and have a look, please come and have a look. It's a lovely facility that's been designed by mums, and the staff love working there. The RUH birth unit has sadly been delayed. This is due to capital availability at a national level. We have all the plans developed, we have the architect drawing, we are just waiting for more news on capital. So I'm very happy to come back and keep you updated. What we have done is reconfigure some of the space at the IUH and worked hard on the environment. So there are some dedicated facilities for mums to have a low risk birth that are slightly out with the main acute unit. But that is an outstanding action we need to work on. Next slide, please. We talked about community hubs. We've been running a pilot down into the centre of Salisbury, which ensures co-location of GPs, midwives, perinatal and infant mental health support workers and health visitors. That pilot has received really great feedback from mums and the staff that work there, and we're just currently formally evaluating it. We also have some temporary pilots in other areas, and we're looking at where we go next in Wiltshire. That links to the ICB model of care about that real importance of starting well and making access as easy as possible for pregnant women. Thank you. Next slide, please. So what did COVID do to maternity services? There were some clear actions that we had to take. A lot of mums and families found it really difficult because we had to stop some partners coming to scanning appointments, and we had to limit the number of women of support people that women could have when they gave birth. That was really difficult and it caused a lot of concern. So again, we worked with our Maternity Voice partnership in those mums to get the messaging right. We did introduce exceptions so that we could provide support for those mums who had particular issues. And I'm pleased to report that all services are now back face to face. We did have to suspend home births at the IUH and at times at Great Western. That was due to COVID, but also due to an increasing pressure we're seeing in maternity, which is around our maternity workforce. I'm pleased to report that home births have now started again. And whilst we had to temporarily suspend home birthing at Chippenham, they are now open again, and we've had babies born at Chippenham, which the staff are thrilled about. One of the other things we saw is a lot of nervousness from women around having COVID vaccinations. So there were some very targeted campaigns around some of our more deprived areas and around some of our areas of the population. That saw for BSW a really good uptake for pregnant women having the vaccine, which really supported good outcomes for mums and babies. Thank you. Next slide, please. You may remember the term continuity of carer. Continuity of carer was a national initiative which aimed to ensure that a mum only saw the same or a very small team of midwives throughout their antenatal and postnatal journey. We were doing really well in Bain, Swindon and Wiltshire. We had a number of pilots. We had a very successful pilot down in Salisbury for mums who'd experienced previous pregnancy loss, and a really good pilot up in Great Western targeting mums from areas of deprivation, particularly younger mums. Due to the national shortage of midwives, the decision was made by the chief midwife of the NHS to cease the continuity of carer models because there was not enough staff to deliver that and safe staffing during COVID. We decided to continue with the Great Western model because it was having such good outcomes, and we're currently in the process of reviewing what does continuity of carer look like with the workforce we have. And again, I'm really happy to come back at any stage to describe that to the committee. Next slide, please. A big bit of work is around making sure that women have really good informed choice and that they get personalised care. So I'm delighted to update the committee that after years and years of handheld notes, so those of you might remember carrying around your packet of notes, which was all written by hand, we now have an app for mums. We are supporting mums who might be digitally disadvantaged, but this means that they can have access to an electronic medical record for their maternity care that links in with other systems. We've also worked with mums to create a Maternity Together website that has loads of resources on it that really helps promote that informed choice, particularly around place of birth. Next slide, please. We've been doing a lot of work around equity and equality, and that's just making sure we understand our local populations and we're delivering the care we need. It's a big meaty document, but really happy to share it if people would find it interesting. Next slide, please. There are some other new bits of transformation that have come out since we went on that journey, and I just wanted to raise a few of them for you today. We're delighted that this week we've launched Ocean, and Ocean is our new maternal mental health service, providing very bespoke psychological support for women who've had previous birth trauma, women who've sadly had a pregnancy loss or neonatal loss, and those who have a fear of pregnancy. That's running across all of our providers with dedicated teams of staff working together. I've touched briefly previously on treating tobacco dependency and increasing the numbers of smoke-free pregnancies, and that work's continuing. We were fortunate to have a successful bid around perinatal pelvic health services, and this is an area that causes a lot of concern for women who do suffer pelvic health issues after they've had a baby, particularly if they've had birth trauma. And we've got a new service that now provides dedicated early preventive support for those women. And another group of women who have really had not an ideal pathway in the past is those women who are type 1 diabetic. And we've been able to secure funding that all of those women now access what's called continuous blood glucose monitoring, CGM, which makes it much easier for them to manage their diabetes while they're pregnant. And it also means that we're reducing the amount of time that mums might need to be separated from their babies when they're born, because they're born a bit sooner than we would like and need to go to a tertiary unit. By monitoring these women in a different way, we're able to keep those babies and mums together, which is so important at the start of their journey. Next slide, please. Another key focus, you may well all have heard it, the very distressing updates that came out of something called Ockenden and East Kent, which were reports into safety within maternity services. There are over 60 actions that come from that report that have been implemented across all our providers. And they range from making sure we're optimising preterm baby outcomes, making sure we've got good, safe culture with teams communicating and working together. And really important, we are listening and hearing mums, ensuring that we're giving them the birth and care that they're requesting. Across our services, we've done evaluation, and we are content that we have safe services in BSW, but all of our dashboards are now reviewed every month in a dedicated safety forum, and any issues are escalated into our LMNS programme board. Thank you. Next slide, please. So that was a very whistle-stop tour. I'm really happy to take any questions, but I just wanted to update you on this is what we said we were going to do, this is what we've done, and there's, as always, there's more to do. Thank you.
Lucy, thank you for the detailed report. I was going to ask a question about the Ockenden report, but you had it there at the end, so that was good to see that there's been learning from that. Committee, any questions? Councillor Gordon King.
Hi, Lucy. Good to see you again.
Good to see you, Gordon.
Yeah, the referring back to the journey as you described it, the freestanding maternity units at Bolton and Trowbridge were due to close, but were also due for redevelopment for aftercare and other things. You know, is that programme still going to go ahead? I can't remember seeing it in your presentation. And secondly, did you ever develop your dad's app?
Hi, Gordon. So yes, we did the Dad's app. It's called the Dad's Pad, and it's out there, and it helps Dad to learn how to change a nappy, how to support Mum. So yes, really happy to share the detail of that. But yes, it's been done. In terms of your question, Trowbridge and Bolton did cease births, as we described as part of the programme.
That's right.
There has been work in both sites, just looking at really improving the environment and looking at what postnatal and antenatal care can be delivered. If I'm honest, that was slowed down due to COVID. It's been reinvigorated. Porton has had some work done to it, and within Trowbridge, it's part of that conversation, as I described, around hubs and what could look differently, particularly around breastfeeding support. So I would describe it, Gordon, as a work in progress.
Thanks, Lucy.
Thank you. Councillor Pauline Church.
Thank you for that. I just want to understand how our quality of care compares to other areas in the Southwest or indeed the country. Thank you.
So really happy to share a more detailed quality report with you, but as I alluded to when talking about Ockenden and East Kent, our dashboard shows that our services perform well. Our still-based birth rate is lower than the national average. Our transfer rates are lower than the national average. It's something that we keep a close eye on because it can change at any time. Maternity staffing, midwifery staffing was a concern. We've just recruited 13 whole-time equivalent midwives into the RUH, newly qualified. So I think the recruitment and retention work we're doing will help with that. But if you look at our dashboard at the minute, there are no areas that are red. There are a number of ambers that we are watching, but I would describe us as performing well when you compare us to the Southwest and when you compare us to the national picture. Just in terms of how we are assuring ourselves of that, throughout December and January, we were out with the regional chief midwife and the LMNS senior team, including our lead midwife. We visited all sites. We talked to mums, we talked to staff, we reviewed all of their returns, and that was an eyes-on look at what services are we delivering and what do mums think of those services. Our Maternity Voice partnership also regularly is being, now it's able to be back face-to-face, goes into each maternity unit unannounced to talk to staff and mums to get that qualitative feedback. So whilst we are watching very carefully at the moment, I would describe, as I did earlier, that we have safe maternity services, which is the language that's being used, and that we perform well when compared to Southwest and national.
Thank you. Another question from Gordon, Councillor King.
Lucy, I was interested to see in your presentation that young mothers from ethnic backgrounds were more likely to have stillbirth. Why is that exactly?
It's a really good question, Gordon. Some of it is around they are less good at accessing prenatal care. Some of it is around they can have more complications. So it's a mixed picture. It follows a national trend and it's something we're looking at. But if you'd like more detail, I'm sure our lead midwife would love to talk to you about it. But it's been known for a while, but it's becoming more prevalent. And also we know during COVID period that mums from those communities were more likely to have complications from COVID. And we saw that when they were pregnant, they were having different types of complications. So it's something that we're keeping a very close eye on, but it's linked to access to care and it's linked to other known complications, things like higher prevalence of cardiac disorders, higher prevalence of diabetes. So it's multifactorial, Gordon, if that makes sense.
It does. It's just a shame, really, and I'm glad it's on your radar.
Thanks, Gordon.
Irene, you've got a question?
Was I? Oh, yes. I'm surprised at that response because I've read that there's a major issue about ethnic minority mothers being marginalised because people don't take on board within a white service area what their needs are. And it's one of the issues listed amongst institutional racism.
It's a really helpful comment. What I would say is that we have done, through COVID, as I alluded to earlier, a huge amount of work about supporting mums from those communities. Our MVP chair is from that community as a figurehead and goes out into the communities to talk to pregnant women. We also have a number of midwives who lead specialist antenatal and postnatal classes who are also from those communities, because evidence also shows that sometimes relationships are better when you're talking to someone who has the same ethnicity as you. So I can't describe for every service, but for maternity, if Chaya, who is our chair, was here, I feel really confident that she would describe that we've done a lot of work to overcome that. So when we talk about maternal outcomes, my feedback would be that is linked to historic health and access issues rather than that institutional behaviour, because I think we've come a long way in maternity in that space. I couldn't describe that for every service. I'm just describing what I know has happened in maternity over the last 2 years.
Thank you. And a question from Diane.
Hi, Lucy. Nice to see you again. I would just like to go back about the home births. I do understand that you obviously weren't able to do that during COVID, but I'm also wondering about, you've now got this lack of continuity of people having the same midwife all the way through. Is that affecting the choices about home births that people are making now? Thank you.
Really good question. So when we talked about this before, we know that our home birth rate and the national home birth rate, we track that, is actually quite low because women are choosing not to have a home birth. When we speak to mums, the main reason for that is they feel safer in a hospital environment, which is why we've got the alongside midwifery unit as a middle ground between the two. The home birth rate traditionally is higher in South Wiltshire than other areas, and that's mainly because there was less choice. We're starting to see a slight increase in home births, and we've had to be really careful over COVID because we did see a little bit of a spike in something called free birthing, which is when women were choosing to deliver their babies at home with no medical support, and that obviously is a significant risk. Continuity of care and relationship is important in home births, but I think the main reason for not seeing a huge increase in home births is that women's fear about not having that medical intervention if they need it through a home birth experience. When we look at continuity of carer, where we are trying to do that with the limited staffing we have, women who choose early to have a home birth, we are trying to keep them with the same midwife. But it's that choice discussion, I think, that's really important at booking. So when a mum's 10 weeks pregnant, just to make sure that they've got all the information to make an informed decision. So it's something we need to watch. But when you talk about home births, it's less than 10% of our total births, and that mirrors the national. Whereas the alongside midwifery units, we're seeing a big spike because women like the option of having a midwife-led birth. But if something goes wrong, they just need to go through a set of double doors to get all the support for them and their baby. So I think it's a change actually in what women want. And also, we talked through the service reconfiguration programme, didn't we? That we're seeing more complexity with mums and more acuity. So we're seeing older mums, we're seeing mums that are bigger, and that they're more likely to need an intervention. So I think times just change, needs just change. But we need to keep an eye on that continuity and supporting mums that if they feel they would like to have a home birth, they have the confidence to have one by seeing that smaller team of midwives. So it's one of the areas we really need to focus on as we grow our workforce.
Thank you. Any further questions from the committee? Councillor Monica Devendran.
Thank you so much for the comprehensive presentation. I just wanted to find out, is there any medical intervention for mums who have normal pregnancy, any idiopathic cause, who are just normal, but they have stillbirth? So in the ethnic minority, because I was one amongst them who lost my first baby. So I just want to know, has any research gone into this particular cause? Because I know that you've said if there's any pre-existing medical condition or access to public care, then there is a risk of a stillbirth pregnancy. But in general, has there any research gone into idiopathic causes wherein it results in stillbirth? Please, thank you.
Hi, firstly, I'm really sorry to hear about your pregnancy loss. I don't know the answer to that question. I will ask one of my clinical colleagues. If I could have your details through the chair, that could be provided, or through the support. I'm really happy to come back to you. Our lead midwife, I'm sure, will be able to talk to you in detail about that.
Thank you. Yeah, we can, Henry, I'm sure you can send contact details through. Anything further from committee? No? Okay, in which case I'll move a resolution that we note the detailed update from the BSW Integrated Care Board on the transformation of maternity services following the rapid scrutiny exercise undertaken by this committee in 2019-20. Could I have a seconder for that, please? Thank you, Gordon. Any objections? No? Great, in which case that's moved. Thank you very much, Lucy, for your time this morning and for the comprehensive update and for taking questions from members. It's appreciated.
Thanks all. Take care, everybody.
We shall move on then to item number 8 on the agenda. This is the business plan and service plan update. On page 17 of the agenda pack, we have a report on how the council's activity will meet the priorities of the business plan around ageing and living well. To allow more time to consider this subject, the committee received a very detailed briefing on this last week, and the slides and notes of that discussion have been circulated to members. That session was recorded, and a link to the video will also be circulated once available on the Councillors Hub. To introduce the report, we are joined by Councillor Jane Davies, Cabinet Member for Adult Social Care, SEND and Transition and Inclusion, Lucy Townsend, Corporate Director of People at Wiltshire Council, and Emma Legg, Director of Ageing and Living Well at Wiltshire Council. As we received a very detailed briefing last week, I think it's sensible that we ask our guests just to provide a very brief overview of the plans, and then we'll move straight to questions. Thank you. Ah. Right, okay, thank you.
Yeah, a few issues with the mic, so it hasn't brought my name up. But to introduce myself, I think I do know most of you, and I'm Emma Legg, Director for Ageing and Living Well within Wiltshire Council. And Dan, did you want to introduce yourself?
Yeah, hi, Dan Wilkinson, the head of the Learning Disability and Autism Service for Wiltshire Council.
So as the chair has said, we did discuss this in some detail last week. So I do just have a very brief overview, and then very happy to take questions or any notes to be made. So in terms of the service plan development, this process began in December 21 to identify our key activities and service developments in order to support the corporate business plan objectives. So you will see within the report that there are 13 planned series of activities across 7 service areas within adult care as a whole. So that covers Ageing and Living Well, and also the Directorate of Whole Life Pathway. So you will also see that the objectives and aims directly address 6 of the 10 business plan mission statements. And I think that demonstrates to us that the scope of the work being undertaken within adult care has a significant impact across the corporate business plan as a whole, and is fundamental to the overall delivery of the business plan. So the areas covered: we live well together, staying active, we are safe, we have the right skills, the right housing, and are involved in decisions. The majority are under the Living Well Together heading, as you may expect, but as I've said, I think it's clear that there is a real breadth and depth in terms of the work that we're undertaking. It's also important to note that there are either key performance indicators already in place against the activities that we're undertaking, so that we can measure the outcomes and the impact for our residents. And if they aren't already in place, they are under development through our performance and outcomes framework. One key point that I really wanted to highlight to you this morning is that prevention is a key theme that you will see running through the majority, if not all, of these areas and the work being undertaken. Just to highlight a couple of key examples to note: the development of our prevention and wellbeing team. This is a new service working with individuals who are on the edge of adult care eligibility, and we believe that with an intensive period of support, we can keep them within their communities and receiving a much broader level of intervention that actually helps them to deliver their outcomes. We have the intensive enablement service, which is also a relatively new area for us. This service shares an approach with our existing reablement service and focuses on time-limited support for people in their own homes to maximise their independence for people with complex needs, that may be mental health, a learning disability, or autism. And it focuses on preventing escalation of a crisis that may involve an admission to a hospital. And absolutely, that's what we would all want to avoid, because we know that the longer term outcomes will then be much more challenging. And finally, we've also are developing a transitional safeguarding approach with our colleagues in Children's and Family Services. And this reflects the importance of that, period in a young person's life as they move from childhood to adulthood, and trying to smooth out the difficulties they can experience going between services, and a focus on keeping people safe, but also enabling them to take those positive risks that we all took, and we expect our families to be able to take as well. So it was really just to highlight that prevention approach and how that is driving so much of the work that we're doing in terms of managing demand and delivering outcomes for individuals. So that was really just a high-level summary. You have the report, and we're very happy to answer any questions that you may have.
Thank you, Emma. And I think Councillor Richard Clearer, the council leader, would like to add something on this.
Yes, thanks, Johnny. I wasn't going to, but I've just been sort of listening to that. And I think members should be taking a huge amount of comfort in the extent to which, and I had no idea what Emma was going to say, the business plan, I seem to carry it around with me permanently, but the business plan is actually being put into action, delivered, made real through these service delivery plans and the work that officers are doing. The fact that it is being referenced so frequently and so coherently, I think should be giving us a great deal of comfort that the strategy, the direction we've set out is absolutely being delivered. It shouldn't need saying, but I think it really is important. And again, the underpinning of prevention through that, and when you look at the core principles inside the business plan, the need for that prevention is critical. It gives me a great deal of comfort. I was really pleased and impressed with what I've just heard, and I think it just needs mentioning.
Thank you, Richard, and thank you, Emma, for the update this morning. And as we said, you know, we did receive a very thorough briefing from you and the team last week as well, which was very welcomed, and there were questions at the time. But we'll open up for any further questions, and I know Gordon has got a hand up, so I'll hand over to you, Gordon.
I've got one question really. I read all the paper that you sent through, and first of all, I commend it for its thoroughness. It's very good. Lots and lots of questions I might ask of that, but we'd be here all day. But one thing that did strike to me was in a couple of areas is the staffing levels and the problems with recruitment, and I just wonder, you know, what plans we have to alleviate those problems, how we're getting on with that, and secondly, you mentioned the KPIs, and the committee could see those KPIs and get a regular update of performance against them.
Thank you, Gordon. Yes, I mean, I think it's absolutely fair to say that there are workforce challenges through our adult social care, whether that's within our private providers or whether that's within our teams within the local authority. If I start with our teams in the local authority, we are doing a huge amount of work. We are currently refreshing and finalising our workforce strategy, which is going to be our kind of key framework in terms of how we move forwards with this. It is as much about retaining our existing staff as it is recruiting new people in. We're also aware of what makes us an attractive employer. And for social workers, for instance, it is how we provide support to them to do their role. So continuing professional development, supervision, those training opportunities. You know, there's so many options for staff at the moment in terms of where they want to work, and we absolutely have to make
Caseload and
those.
things like that.
Sorry?
Caseload and
Yes,
things like that.
yes, absolutely that. So how can we make our staff feel supported and that they have the right resources to do the job that they want? It is across the board. It is social workers. It is occupational therapists. We've got some very, very good examples of career pathways at the moment. So we are doing a lot around apprenticeships and training, kind of grow your own staff. So we have a number of staff who are undertaking the social work apprenticeship and also the occupational therapy apprenticeship. In probably a year or so, that will start to really give dividends for us. And these are staff who've worked with us for some time in other roles, so we know that they're committed to Wiltshire Council. We know that they value what we offer. So I think that's going to really support us. But it is an ongoing challenge, and we are very focused on it. And that workforce strategy, again, we'd be happy to discuss that in more detail when it's finalised and ready to be published. In terms of the KPIs, yes, so we do have dashboards within the service areas, and we are also amalgamating those into that overall directorate level dashboard. And again, we can bring that back to share with committee going forwards.
Thank you. And Richard, you wanted to come in on that?
Just to add on KPIs, be careful what you wish for. There is a huge amount of data. We are providing now on a quarterly basis through Cabinet a very sort of top line set of data. There is a lot more there to drill down into, but you may find yourself a little overwhelmed. It might be, it might be worth taking it one section at a time if you want to sort of meaningfully look at the data that's there and understand the KPIs. To ask for it all in one go would be, yeah.
How you bring them up and
You need to put your mic on.
level, but having the KPIs and seeing performance against them is the means of providing scrutiny.
Okay, thank you. Any further questions from committee? Diane?
Just popped into my mind. So, thank you. You were talking very much about prevention, which is obviously is what we all want, and the use of the prevention and wellbeing team. And I'm just wondering, I'm just looking at what it's saying here. You're looking at approaching reviews of people with small long-term packages of support, etc., etc. And I'm just wondering where the reduction, I'm going to use the word daycare, even though it's used differently now, how much that's affected it, because I am aware that very, very few of the original luncheon clubs, daycares, whatever you like to call them, actually applied under this new funding agreement. I am aware of a lot of people that now have nowhere to go, which is not helping with the prevention, and wondered where you're going with that, please.
Yep, so the prevention and wellbeing team do work with some of the adults who may have been accessing those services, but their focus at the moment tends to be people who are new to social care. So those are the types of people who are coming to us initially and asking for that type of support, and that when we look at their overall circumstances, that those are the ones that we think this service can offer them the best outcomes. It's often people who we haven't known before. So that's where a lot of their focus is. You know, they are working with people in terms of managing those long-term needs in a much more innovative way that isn't dependent on kind of paid for services. So if that is required and they do need a Care Act assessment, then absolutely that is what we will do, and that is what the support plan will include. But it is trying to look much more broadly across the piece and very much more focused on kind of universal type community services rather than those that might be focused at an individual cohort. I don't know, Jane, were you wanting to come in specifically?
Yes, I was just going to respond to your question because obviously you're concerned about lunch clubs, etc. I'm not aware of any of them that have closed since the change in grant conditions. You know, if you want to talk to me afterwards about one. I mean, lunch clubs are brilliant, but what we need to do as a council is make sure that our support goes to the most vulnerable. We also have a responsibility to provide support equitably across the county, and you know this wasn't the case before. The open framework is continuously open, and I know that officers in commissioning will work with anyone from a lunch club or any other day opportunity. New clubs are coming forward to support them in getting on the framework, and we would really encourage and like them to do that, because by doing that we can assure people who are wanting to visit the lunch clubs that all of the safeguarding is correct, all their policies are correct, and we can support the lunch clubs by offering officer advice on that. It's a big thing for me that I think we need to empower day opportunity services and work with the voluntary sector to really make sure that the people who are in need of care get access to care. We need the provision to be in the right place at the right time. For people who have vulnerabilities but aren't Care Act eligible, for example, if they have a good pension or something, my mother would fall into that category. She wouldn't be eligible for social care, but she would still like to sort of engage in things. And we now have a new focus in commissioning. I believe we have 2 officers appointed specifically to work with the voluntary and community sector to make sure that our offer is well meshed. You know, what the council can do, what the hospitals do, that we work together more effectively. And you know, so please let's have those conversations about getting, you know, David is sitting next to you and I know he talks about the stigma attached to social care. There shouldn't be a stigma. Nobody is embarrassed to use the NHS. Nobody is embarrassed to apply for their pensions. It should be the same for social care. And we really need to make sure that we get it to the right people at the right time. So thank you for your question.
Can I just say thank you? And I completely agree. I haven't worked in social care for most of my life. There is still that stigma. I will talk sort of locally. I'm from Calne, and I think there are lots of things going on in lots of our areas that are supporting people, and I'm particularly keen on supporting people that are not at the moment needing social care input. You know, they're needing support for social isolation, for their mental health, carers in particular. And I would like at some point, if I could, to actually have a conversation about how that could work better with social care. You know, I mean, I run a support group every Tuesday morning, and we've got 50 people, or older people, but you know, I have to go to area ward and all sorts of different things for that. And I just wonder if there might be other ways around it. That's all. But thank you.
I was just going to say, looking at Emma, we'd be very happy to have that conversation with you. Yeah, we'll organise a meeting, shall we? Thank you.
Thank you. I did have Trevor next on the list, but I noticed that David is probably on this topic, so.
Yeah, just for the record, I didn't suggest that there was a stigma associated with being assessed under the Care Act. I think I just jokingly referred at one point to the fact that I'd met a 90-year-old person, a lady in one of these lunch clubs, and I sort of politely asked her if she'd ever been assessed in any way for social care, and she responded, "I've never seen a social worker in my life." And there was nothing negative about social workers. It was simply her own description of her own situation. And the sort of the bigger truth that comes out of that situation is that a number of these lunch clubs have directly told me that they have no people on their books who are assessed under the Care Act and do not expect to have any, and therefore will not be eligible to join the open framework. It's just a fact. You know, there are a few who have one or two people who have been assessed, but most of them have actually told me we have nobody in our ranks who has been assessed under the Care Act, and therefore they would not be eligible. Now, it's just a fact. To end on a positive note, it's really good to hear that you've taken on 2 people to liaise with the voluntary sector. That is great news, because I think the more that the council can work with the voluntary sector, the better. There's so much synergy to be had there. And could I ask, I think it would be great if the details of those people, or the fact of their existence, could be made known to the volunteers who run the lunch and friendship clubs, just in case they want to have a conversation if they are, starting to struggle or have some needs they'd like to discuss.
Certainly. I mean, thank you for your clarification. I understand what the point you're making. I think, though, that lunch clubs shouldn't be just saying, well, we have no one who's been assessed. We ought to be supporting and educating the lunch clubs about helping people to have those conversations and about how to call advice and contact if you have concerns about people. I think that's an important piece of work going forward. We need to help them to be proactive. We need to empower them and all of our voluntary and community sectors to feel they can contact the council and be in touch. I mean, all of the lunch clubs do have the contact details of commissioners who did the open framework piece of work, and I know there have been a number of contacts, and that route is still open and will remain open. But yes, I'd be very happy to do some more communication about that, because it's a piece of work we're very, very keen to take forward.
Emma?
Yeah, just to kind of add on to that, really. So it is very early days in terms of the additional resource that we are bringing in to support that piece with the VCS and community groups. I think it is about making contact with them, but it's also a much broader piece about how we have a much more kind of cohesive network that they know what we can do and vice versa, so that we are very much working together, and also playing to organisation strengths. So we know so we can understand what the VCS are able to offer us and vice versa, so that individual support plans are more bespoke and based on their individual circumstances and what they actually want to achieve, rather than a kind of over-reliance on paid for care and support in that traditional domiciliary care type approach, because there's so much more that we could and should be doing around, giving people those positive outcomes, and the VCS and community groups are often the key people who can actually deliver that sort of added extra. So that's very much the approach we'll be taking forwards.
Great, thank you. We had a question from Councillor Trevor Carbon next.
Thanks, just a specific question. I didn't see the briefing, so shut me up if you've already covered this, but I'm looking at page 25, the increase says there's been a slight increase in the number of people receiving a direct payment in LDAS from 154 on the 31st of March to 195 on the 31st of October. That doesn't look like a slight increase. It looks like quite a dramatic increase. Can you explain what's happening there?
Yeah, happy to talk to that. So within adult social care, that's a slight increase. You are correct. Within that service, it's quite a significant percentage. But it was just about highlighting the fact that we've still got some way to go around DPs. We're not quite where we should be. There's challenges around recruiting personal assistants and things like that. So it's just to not over-egg the achievement, basically saying that we've made some progress, but we still know we've got a bit of work to do.
So where are the numbers going to go from here then? Are they going to go up? Are they going to stabilise?
We want them to go up,
Yeah.
and a lot of the work that's been done within Learning Disability and Autism Service and within adult social care more generally is around supporting people to have much more control over their care and you know, to make more choices. So the hope and aspiration is that it will go up, but I would argue the biggest challenge we've got within social care is recruitment. I don't think anyone will be kind of shocked to hear that. So it's how do we kind of make sure that we've got personal assistants that can support people with the right skill, knowledge, and understanding. So we have seen them go up in the 4 years or so I've been in the council. We have seen them go up, but point in that report is there's still much more to go, and it's just broader than learning disabilities and autism. Obviously, it's that broader kind of adult social care remit. Cool.
Great, thank you. And there was a question from Pip.
On the question of housing, and I've seen all the liaising you're doing, are you also liaising with the Chief Planning Officer or any of the planning officers? Because if certain conditions aren't put in when permission is given and then enforced, for instance, I've got 1,500 coming in just my ward houses, I would like to see something in that agreement as to how many should be for people with disabilities or whatever you want them for, or extra care. I would like to see that not only is it in the agreements, because everybody's doing the local plan at the moment as well, and it could go in, something could go into the local plans about provision for those needing extra care. So I hope you are completing the circle, so to speak.
Yeah, so I mean, housing and care is a real priority for us, and I think that's regionally and nationally, because when we know that housing is a key determinant of health, and we have to include it in our thinking about what makes a good life for an individual. It is a challenging area, but the kind of assurance I can give you, Pip, is that we are absolutely entering into those conversations with our colleagues across the local authority. I think kind of the reference back to the business planning is giving us that steer around where we want to be focusing our resources and who are our priorities. It isn't easy, as you've kind of referenced, and I'm sure you know. And I do think that housing as an area may be something that the committee might want to look at in a bit more detail, possibly, going forwards, because it is such an important area, and we're doing what we can within the kind of housing operations piece that we have within the People Directorate in terms of that early intervention and maintaining tenancies, preventing homelessness. But there is also a much broader context around, the availability of suitable homes. Extra care is something that we do have some in Wiltshire, but it probably is fair to say that we don't have enough. And if we had more provision on extra care, it would give us more options about how we want to support people, particularly as they become older and start to develop needs. So again, that is a conversation that we are having with our colleagues around what are our options, what provision could there be, what facilities could we develop. So it is very much something that we're looking at in more detail.
Just want to say, Pip, that's a great question. Thank you very much. It is something we are trying to address, and not just with extra care for people who are getting older, but also for people with learning disabilities, autism, or mental health issues. And that's what the independent living strategy was intended to sort of kickstart a stream of work around this. But very good point to put it in the local plan. I know that care homes have a mention in the existing local plan, and I'd seek to kind of extend the comments from social care within the local plan.
Yes, I'm well aware care homes are in it. It's the social care housing aspect, which I have technically 60 proposed in my ward, but the developers have come back for housing, general housing, because of course it's not profitable to buy a piece of land and build 60 extra care bungalows as opposed to building 180 houses. So that's why I asked the question, and I do think it's very important that you tell all parishes to put in the local plan not only care homes, which we have, but extra care housing for those who require some form of social care, but not to be permanently, in a care home.
Absolutely. It completely aligns with our ambition for people to live independently, at whatever age they are.
But just bear in mind, all this has to be evidence-based, and we've got to be really careful about definitions. What we might see as extra care might be seen as something slightly different when you come to actual definitions. Some of it may need to be affordable, some not. So this has got to be evidence-based. It can't just be a case of saying we need X or Y. There's got to be the evidence to back it up. Otherwise, our planners will never be able to ensure that it's delivered.
Thank you, Richard. I did know all that, as you were aware of the situation we're dealing with, but I still think one has to proceed and try and get as much as you can to support that in evidence, and the local plan would be an ideal place for it to be.
Thanks, Pip, and thanks for raising that. It was something that came up in the discussion the other day as well. Expressed surprise that the adult social care team isn't a statutory consultee in planning. We consult various other bodies as to what's needed, and yet adult social care isn't. But it's more of a national question, I suppose. Gordon, you had a hand up.
I did. I raised this matter during our Tees meeting the other day, and I said there were two local plans which had very explicit statements with them, but they were South Gloucestershire and Baines. Jane asked me to send her a link of them. I did look at their plans again. Their plans in South Gloucestershire around their policies, CS18 and CS19, as I say, which are very explicit to be consistent with nationally prescribed minimum internal space standards and meet accessibility standards M4/2 and provide 8% of all units with wheelchair standards M4/3 only applicable to dwellings where the local authority is responsible for allocating and so forth. Very explicit statements. I looked at both of their refreshed local plans, as everybody is refreshing their local plans, and 2 points. Richard is absolutely right. It has to be absolutely evidence-based. And secondly, both of these have changed. For instance, Baines have changed their policy H7 to now be about extra care and accessibility rather than making explicit statements about the standard of house. Yeah. And Pip and I sat on an AIDS and Adaptations working group in 2019-20, where we became very enmeshed in this. So.
Great, thank you. Were there any further questions from the committee on this item? No, in which case I'll move a resolution that we note the information on the council's business planning process and activity of the Ageing and Living Well and Whole Life Pathway services following the detailed online briefing provided for committee members on the 11th of January 2023. Could I have a seconder, please? Thank you, Gordon. Any objections? No, in which case that is moved, and we shall move on to, thank you, Emma and Jane and Dan for that. Dan, I think you're with us for the next item as well, which is the Learning Disability Knowledge Cafe and Autism Partnership Update. We've been provided with a report about the role of the Learning Disability Cafe and Autism Partnership in providing a forum for people with learning disabilities and people with autism to shape services that impact their lives. So to introduce this, we are joined by Daniel Wilkins, who's Head of Service for Learning Disability and Autism, And also Jane Davies will be staying with us for this item as well, the Cabinet Member for Adult Social Care, SEND, Transition and Inclusion. So I'll hand over to you both for the report, and then we'll open up to the committee for questions. Thank you.
Everyone, rookie mistake. I did send a presentation as well, just to summarise. I don't know if that's possible. Lucky you, everyone else gets to see me, or you, or everyone else. It's okay. I will talk through it, and you know, you've seen the report, so I will try and bring the report to life. Awesome, fantastic. So great, thanks. Yeah, this is me. I think it's the 6th time I've introduced myself today, so I won't introduce myself for the 3rd time. So the meeting is for learning disabled people. It's not learning disabled people, so I apologise for that fairly embarrassing typo. So the Knowledge Cafe, they meet monthly. It's around having a space for learning disabled people to talk about what is important to them within Wiltshire Council, within Wiltshire, sorry, and this looks at kind of issues around the council, around accessibility, around what's important to people, and what we the approach we've got is, if you could move to the next slide, please, is a Knowledge Cafe, and you may all be familiar with Knowledge Cafes, but for those people that aren't, what it does is it takes away the traditional kind of partnership approach where you'd have a meeting at a table and people would raise their hands. It's actually much more inclusive and there's kind of little tables around, and there will be a topic of conversation and everybody will have a broader discussion. This was a change that was made a couple of years ago, because prior to that, it had been a more traditional type of board, and the feedback that we got was actually it wasn't really capturing the voice of learning disabled people, and people felt excluded by it. So the approach has been changed, and through this you're getting much more of a kind of inclusive discussion, much more engaging discussion, and actually better kind of more representation of views. So again, that's a bit about the Knowledge Cafe. Next slide, please. There's been quite a lot of kind of work, and this slide doesn't really do it justice, but there has been some kind of key bits. Again, as I already mentioned, working with NHS organisations and Wiltshire Council to develop new and existing services, advising businesses, and this is a real key bit around the work that the Knowledge Cafe does. It's about going into Morrisons and other organisations around how can we ensure that we have an inclusive society for learning disabled people, and that's really really powerful. And a lot of discussion is people don't want services. I am a social worker, and the last thing people want is a social worker involved in their life any longer than they have to be. And that's no criticism of my profession. It's a wonderful profession, but actually people don't want to have lifelong social workers. They want the support when they need it. And I think that's a real ethos of what the Knowledge Cafe has been talking about. In terms of kind of continuing that inclusivity theme, they did some training for PAs and bus drivers again, so that if a bus driver is picking up a learning disabled person, they know how to communicate with them, they understand that they'll need to make reasonable adjustments, not just rush off the moment the doors have shut and stuff like that. Really common sense kind of approaches, but really, really quite key. And, developing hospital passports. And the notion of hospital passports have been around for decades. I remember discussing them at the beginning of my training. But what we haven't had is them kind of human formulary kind of introduced. So the hospital passport is literally a one-page. This is me, I'm Dan, this is my medication, this is how I need to be supported in hospital. So it's a really key bit of work. What's really interesting is that there are different versions of the hospital passport. There's no generic template, and that's really unhelpful. So what we're trying to do within BSW is make sure that everyone has the same template. So if you're in GWH or the RUH or SDH, that you have the same discussion. So that's a bit of work that's been done around that. And then in the boxes, there's just some quotes around what people have said about why they like coming to the meetings, and that there's a hyperlink to the YouTube video, which you can click on at your leisure. But there's discussion with people that go to the meeting around what they enjoy. So next slide, please. And yeah, I mean, the priorities on there, living my best life, having good support, kind of being involved in my community, work in employment is a massive theme. The number of learning disabled people in paid employment is shockingly low. Nationally, it's 5%, in Wiltshire around 7%. Jane and I have had lots of discussions around what can we do to improve the number of learning disabled people in employment. Living my life, again, a continuation of the theme, really. People don't want services involved. If we go out and ask learning disabled people, what do they want? Well, they want the same things we all want. Friends, house. They want to, want enjoyment from life, which is what ultimately we all want. So it's around how do we kind of support that, and health select committee. So I'm sure you're well aware of the massive health inequalities of learning disabled people. So I won't repeat what you already know, but we do know that people with learning disabled people do die younger than the general population. They do have, they're more likely to have health conditions. If you look at quality of life as well, so they're kind of, in terms of those indicators, there's a lot of work to be done. And not surprisingly, a group for learning disabled people are really keen to talk about kind of the health. And so there's, lots of good work that goes on there. And the Knowledge Cafe feeds into other forums. We have a Learning Disability and Autism Programme Board. We have a locality meeting and other forums. So there's lots there. The next bit of the presentation about the Autism Partnership, but does anyone have any questions about the Knowledge Cafe? Yeah, hi.
Bear in mind, I've been out of action for 6 months. Where is the one in Warminster? And do the Health and Wellbeing Forum know about it?
I don't know either of those, which is embarrassing, isn't it? I will check those. The Health and Wellbeing Forum do know about it, but the exact location I'll check for you.
Right, thank you. Because we do have a chat cafe, but that's not for learning disabilities, so this must be somewhere else. Thank you.
Okay.
Diane?
Thank you. Sorry, I just wanted to ask a very basic question, really. How do people know about these cafes?
So it's hosted by Wiltshire SEAL, the Wiltshire Centre for Independent Living. They do lots of communication. They contact people. There's a Facebook page. They send out letters and stuff like that. So it's widely promoted from Wiltshire SEAL. Within the social care team as well, we promote them as well.
And I just wondered, just again, curiosity, because there are a lot of our population in Wiltshire do have learning difficulties and or autism. So I wonder how many people actually are attending those. They're just 2 cafes, I think.
Yeah, there's 2 cafes and then there's a Facebook group. Attendance is between 10 to 20, which is small when you consider the general population of people with learning disabilities. But again, always try and look on the bright side, really. When in the previous incarnation, there was kind of 1 or 2 people with learning disabled people going to the forums, and the rest were professionals. So I think it's a step in the right direction. But yeah, say 20.
I think that's why I was asking about how do people know about it, really.
Yeah.
Yes. Okay, thank you.
Okay.
No, sorry.
Emma, you want to?
Yeah, so I think if there are people in your communities that you think would benefit, then absolutely we can, share links to the Facebook group and any information around it. And I think, as Dan has said, we're seeing a definite improvement in terms of that broader engagement and people coming along. But we recognise that, when we think about the number of people just from a social care perspective that Dan's services work with, that's a very large number of people who aren't involved. So, in terms of our work with Wiltshire SEAL and other organisations going forward, it's how are we maximising that engagement? So I think we're absolutely, delighted with where we've got to. But, absolutely recognising, as we said, with the direct payment piece as well, there's always more to do. And our co-production and engagement piece is another key priority for adult social care over the next few years. So, again, we are looking at a much more vast and inclusive co-production strategy about how we're bringing people into many areas of adult care. Obviously, Dan's talked about one today, but there will be a lot of work going on in that space.
Jane?
I was just going to say that Wiltshire SIL is run and led by people with lived experience of disability. So we do defer to them when they say we'd like to organise it like this and that. You know, obviously we have conversations with them, but it really is an example of respecting people with additional needs and saying, okay, what can you give us? It's proper co-production. We try and avoid saying you must organise it like this or do it like that, because we don't know best.
Okay, and Councillor Vigo?
Yeah, great presentation, really inspirational, thank you. Just a question, do you have contacts with existing kind of support groups like Westpilt's MenCap, for example, who are dealing with learning disabled people?
Yeah, we do. We try and make sure that we're connected in with the other groups. But yeah, I think picking up on Emma's point in the previous discussion, it's around promotion and, you know, still in that, I guess, are we still in the post-COVID land? I wonder how long we can say that for. But during COVID, it was hybrid, and then last year it went face-to-face. And it's around trying to find that balance. And within the Autism Partnership, which I'll discuss in a minute, that's where we're trying to find our way as well.
Okay, thank you. So do you want to move on to the next part of the presentation now, and then we'll
if that's
wrap up
okay.
with further questions? Yeah,
Yeah.
Thank you.
So, I mean, the Autism Partnership has had a similar trajectory to the Learning Disability Programme Board. So again, it felt very professional heavy and kind of excluded autistic people. So we've had a recent relaunch and really tried to set some key principles around what do we want from the partnership. And, you know, I think it's what you'd expect. We want to make sure the views of autistic people in Wiltshire are represented by themselves, not represented by professionals. And sometimes I think that happens, and we're quite keen around that. We want to work with organisations to improve lives of autistic people. And again, it's that breadth of society. It's not just health or social care or housing, it's that broader. The autism strategy, which I believe you already had sight of, is that correct? Has the autism strategy already come to this committee before? Okay, apologies. So I will circulate the autism strategy, although we'll discuss the priorities in a minute. But the autism strategy was developed last year. It's a 5-year strategy, and one of the aims of the Autism Partnership is to co-produce the action plan, which I'll discuss in a minute. And again, another aspiration is working alongside existing forums to improve the lives of autistic people. And I think that there needs to be a broader discussion around how do we make sure we're not having the same conversations in silos. Actually, let's have them joined up and make sure that we're not having to go to the same meetings and capture that. So those are some of the kind of key aspirations. Next slide, please. So you won't have seen this, so apologies. So within the autism strategy, there are 6 key priorities, which you can see, but, you know, improving the health of autistic people and reduce health inequalities. I've already mentioned and alluded to the health inequalities of learning disabled people. We know that autistic people as well suffer health inequalities, particularly around mental health, so there's a real focus on that. Supporting children and young people with autism to play, learn and move into adult life. Again, you should just remove the autism. That's what we want generally. We want our children to be children, don't we, and to be well supported. But we know that there are particular challenges for autistic people. So how are we working with children and young people to support that? Again, support autistic young people and adults to access work. Number of learning disabled people in work already mentioned. Nationally, number of autistic people is only around 25%, so still low when you look at a national employment average of around 70%. So there's lots of work to be done there. Again, supporting autistic people to live independently in the community wherever possible. People want to live free lives. They want to live with their friends. They want to have families, and we know that there are barriers around that. So how are we working to address those barriers? Raising awareness. Again, there are still stereotypes of autism which are harmful. Brilliant quote by somebody I need to, you know, that says if you've met one person with autism, you've met one person with autism, and I think that's really absolutely vital, isn't it? And how do we change that? How do we move away from the perceptions and stereotypes of people? And again, if you look at the criminal justice system, unfortunately, autistic people are overly represented within the criminal justice system. So how are we working to support people? And again, the overarching theme of prevention, this is all about prevention. You know, if we ensure that people have their health checks and they're less likely to get ill, etc. Do you know what I mean? So it really captures into that. So let's kind of get in there early and do that early preventative work. So these priorities are the priorities that were set in the national strategy, and we thought it would be prudent to adopt them in the Wiltshire strategy. So next slide, please. So in terms of developing an implementation plan around the strategy, for the next 3 meetings in the Autism Partnership, we'll be looking at 2 priorities each to develop an action plan. And again, I won't repeat the priorities that I've already gone through, but you can see for yourself. So we've got the first meeting this year is on the 30th of January. We'll be looking at those 2 priorities to develop an action plan and so on and so forth. And, you know, the wonderful challenge of co-production is that timeframes are fluid. And I think that I'm really looking forward to meeting in a couple of weeks to find out, to get the views of autistic people and help develop that priority. I'm also mindful that we're already kind of halfway, 5 months into a 5-year plan. So we're ready, time is already ticking. So it's really important that we tick along with that. I guess the other thing as well with the Autism Partnership is we want to increase the number of autistic people. At the kind of relaunch we had in November, we had 10 or so autistic people, but at the end of this presentation, I've put the Autism Partnership inbox, and we've had interest through that from people that want to come along. The meetings are hybrid as well, and we're using Zoom because the feedback from autistic people is that Zoom is a much better way of communicating than Microsoft Teams. So we're having that hybrid approach. So yeah, that's my summary. Has anybody got any questions?
Any questions from the committee on this item? Diane.
Okay. These are thoughts, really, more than anything. I mean, obviously, as you know, I'm the chair of Wiltshire Service Users Network, and we run the Autism Hub. So I'm very interested in obviously working with people with autism. And I know it should be very focused on that person or individual. One of the things I would be quite interested in is because an awful lot of people either with learning difficulties and or autism still live at home, and they're still supported by their carers. And I'm just wondering how you're looking at supporting, if you're looking at supporting the carers, because an awful lot of these people would not be able to actually maintain a lot of their independence with that support. But I also know there's a lot of difficulties there.
Yeah, so alongside this piece of work, I met in November with Wiltshire Carers Network and the Wiltshire Parent Carers Council. So there are ongoing discussions, and as you've rightly said, we've got we have a lot of people, autistic people, learning disabled people in their 30s and 40s who are living at home, and are actually now getting into that situation where they are becoming carers for their own parents who are getting older. So there is that can't say twin track, but you know, there is that concurrent piece of work going on. But I think this is what I alluded to earlier. It's around making sure that where discussions are being had in different forums, that they're joined up and they're being briefed, and that's part of this work as well. Louise Rendell from your organisation is part of the Autism Partnership. And again, that's something I should have said as well. We have other representations from kind of health and social care organisations as well within that meeting.
Thank you. I was just going on to criminal justice because I'm also very, very aware of the difficulties that people with learning difficulties and autism have if they happen to come in contact with criminal justice in any shape or form, particularly with the police. So it's just information. It's happened recently, a meeting with the Chief Constable, and he's recognised that their staff do need training. That's just one issue. And also they're going to look at having people with autism on one of their boards. So that's just information, which is a good step forward, really. Thank you.
On that, one of my team managers recently went and did some training with newly qualified constables, which was great. And we have close links with Mike Hughes, who's the mental health liaison officer within the police. So those discussions are ongoing. But you're right, it's a massive issue and one we need to address. Thanks.
Thank you. Any further questions for Dan? No. Okay. Well, Dan, thank you very much for the update. I'll move that we note the information provided on the work of the Learning Disabilities Knowledge Cafe and the Autism Partnership as forums for ensuring that learning disabled people and autistic people are involved in shaping services that impact on their lives. And also that Wiltshire Council's Autism Strategy 22-27 will be circulated to the committee. Can I have a seconder for that, please? Trevor, thank you. Any objections? No objections. Great. Thank you again for your time, Dan, and thank you, Emma and Jane, also for your input. We've got a couple more substantive items on the agenda, so if the committee will excuse me, I'll just pause the meeting for just a couple of minutes for a very short comfort break, and see you back here in 2 minutes, if that's all right. Thank you. Okay, thank you, everyone. Apologies for that. We'll carry on. We are now on to item number 10, and this is the health scrutiny inquiry session that we have proposed, looking at the issues around patient flow through hospitals and the sort of systemic factors that are presenting barriers to flow. So we have a report which was requested by the committee in November, which outlines an inquiry session into this issue. We agreed we wanted to understand the barriers to patient flow throughout the system and to potentially identify further areas for scrutiny. As you'll see from the report that's been circulated, the focus we are proposing is that the factors contributing to the extreme pressures currently being experienced and reported in urgent care and the systemic challenges impacting on patient flow through acute hospitals used by Wiltshire residents. So just to be clear that while the focus is on urgent care, to address that, we need to look at take a broader look at challenges across the whole system. Although the report was written by the scrutiny team, I'd also like to thank Mel Nicolau, Head of Resources Commissioning at the Council, for her input into it. So once the committee agrees the methodology today, a date for the inquiry will be agreed. It'll probably be around April time, as we wanted to avoid sort of the winter period when obviously teams are hard at work dealing with extreme winter pressures. And Gordon and I will undertake further work on the detailed planning for the session. We'll then bring an update to the committee's next meeting. So were there any comments or questions from members on the report that's been circulated? I know Councillor Vigar needs to leave shortly. He's just given me just a short question asking whether half a day is enough time for this session or could it be longer. I think it's important that we have the flexibility to run on should we need to sort of into a mid-afternoon session. So we certainly won't set a strict time limit on it. We will, we wouldn't want to be sort of ending a session mid-conversation on an important topic. So that's certainly something we will we'll factor in. Was there anything else that members had on the report? One thing we are keen is that we are receiving questions from members in advance of the inquiry session so that we can ensure that the various stakeholder groups who will be attending and the partner groups attending have the responses to questions, the information they need, the staff members they might need present at the session to be able to address those queries. Gordon, you need microphone.
I was going to say, or indeed if somebody's missing.
Well, yeah, indeed. Councillor Vigar.
Yes, as I'm still here, there's just one little question that was raising in my mind. Now, given everything we know about the current situation in the NHS and its relationships to the care system and the interconnectedness of the two, point I in this, do we have sufficient care home domiciliary care capacity? Absolutely. But I'd sort of add to that, and to what extent does that capacity or the lack of it impact on the urgent care situation? I guess that's taken as read here, but it wasn't quite made explicit.
Taken as read, but no, you're absolutely right. Those are exactly the kind of questions that we'll want to be, taking a deep dive into at this session, because that is one of the key factors. There are a number of key factors, but that, of course, will be one of those barriers. Others being, ambulance conveyances. Are patients being conveyed to hospital who really need to be going to hospital, or could they be directed elsewhere? And GP provision, are people accessing urgent care due to a frustration at not being able to get primary care? All these sorts of factors that we'll need to take a deep dive into. Anything else from committee that they'd want to raise at this stage as we sort of refine this methodology? Pip? Because we're setting up a dedicated inquiry session for the committee. Yes, I believe so. perhaps Henry could clarify that, the sort of in terms of reference or whatever.
Yes, we've never done an inquiry session before, so this is a new kind of scrutiny exercise, but it is one that other councils do. I think the idea of going with a big committee level session, although not a formal committee meeting, is just to involve all of the members rather than a small group, and also to bring a lot of providers and stakeholders together on one big event, so we're all in one room and can discuss all the issues rather than spreading it out over a lot of meetings, which inevitably divides up the issue into several mini issues. So that was the thinking of the committee, I think.
Okay. Okay. Anything else from members? We do have Fiona Slevin-Brown with us today. Thank you, Fiona, for being with us. Is there anything you want to add at this stage? Have you had an opportunity to see the report that's been circulated? Yeah. No? Okay. Great. Pauline.
Thank you, Chair. I'd just rather try and work out what the outcomes we hope to get from an inquiry session. It's not clear to me how that differs from a normal task group and what benefits that would get. It looks quite like a nice big piece of work, lots of stakeholders involved, but I'd like to understand what outcomes we hope to achieve. Thank you.
I think ultimately it's about reassuring our residents that we are very alive to the concerns that are reported in the media constantly around the pressures in the system. And so we want to be able to bring everyone together, because I think in the past we've had individual stakeholder groups come to committee and talk about the pressures in their particular part of the system. And we felt it would be beneficial to bring the whole system together in one place at the same time to have a look at these issues in more detail. And so, for example, if there's an issue with ambulance queuing that is related to people not being able to get out the other end of the system because of perhaps capacity issues with social care, let's discuss this all in one place with all stakeholders present, rather than hearing about one element at one meeting and then 3 months later we hear about another element at another meeting. The whole thing is connected, and I think it's important that we look at it all in one session with all those stakeholders present at the same time, if that makes sense. Okay, Gordon.
Yeah, I guess for me, it wasn't really to be overly prescriptive about either the method or the outcomes, because they will perhaps present themselves in a way, but I think, except for in the broader sense, that it has to benefit, those outcomes have to benefit in some way the patient experience from the time their incident occurs to the time that it gets resolved, and considering all the things that might happen to them along that way. So it's going to be a true inquiry in that sense. We're going to look at everything. We may not all be in one room at the same time. We might break up into little groups and consider each part of it or whatever and come back to each other. We haven't actually organised that day yet, but that's where the outcomes will hopefully emerge.
Indeed, and the outcomes could be, a series of recommendations, perhaps, as they are from any scrutiny exercise. Anything else from members? No. Okay. Well, in which case, I'll move a resolution that the Health Select Committee will hold an inquiry session as set out in the report, with arrangements to be developed further by the scrutiny team in consultation with the chair and vice chair of this committee, and reported back to the committee's next meeting. Can I have a seconder for that? Thank you, Monica. And any objections? None. Okay, in which case we will move on then to item 11 on our agenda, which is the Bath and North East Somerset, Swindon and Wiltshire Integrated Core Strategy Update. On page 39 of your agenda pack, we have a report setting out the process for designing and adopting the BAINS, the BSW Integrated Care Strategy. Richard Smale, Director of Strategy and Transformation for the Integrated Care Board, joins us to present the report. So Richard, I'll hand over to you first, and then we'll open up to questions. Fiona, you're also presenting, or?
Thank you, Chair. Supporting Richard with the conversation. I think it's probably important to open by saying that we are going to Health and Wellbeing Board next week as part of a series of conversations locally, engaging colleagues and wider stakeholders in the development of the strategy. So I think it's just important to note that it's come here to set out the process, but that obviously we're at the beginning of a conversation that will allow us to develop and evolve the strategy over the coming weeks.
Great. Okay, that's noted. Thank you, Fiona. So, Richard, you've got some slides, I believe, to talk us through?
They'll be coming up shortly. Thanks, Jim.
Not got them here. That TV went into standby mode.
That's a good start, isn't it?
Great,
So-
thanks, Richard.
Yeah, so there's a few slides here. This conversation, as Fiona says, is really teeing up a piece of work, really. It's a bit processy, and we don't want to obsess about the process today, but we just want everyone to sort of really be clear on what the task we've been given to do and how we want to do it in a way that works for our health and care system and works with the population of Wiltshire in particular in this context. So I don't know if you could just click us on for the next slide. So this slide just sort of explains we're statutorily required as Bain, Swindon and Wiltshire to produce an integrated care strategy by the 31st of March 2023. And Richard, as chair of the Integrated Care Partnership, that's the body that is required to produce that. Now, there's a great danger at this moment because we've got local health and wellbeing strategies being developed in all three areas that we duplicate, confuse, produce something at odds with something we've said locally. So what we are trying to do by working with all the partners in the three local areas is say, let's not make that mistake. Let's not just produce the same thing twice, because that's not helpful. But let's really think about, A, what are the DNA type messages that are consistent in these pieces of work? And then what are the unique lens that we might apply when we're talking about it from a system perspective, as opposed to the sort of local lens that you will have in your health and wellbeing strategy. So we are trying to work with partners around that. It's not a perfect world, but that's how we're trying to get the best out of those two things. We've also just listed on this slide, the NHS likes its planning processes and likes to task us with specific plans about delivery. So the integrated care plan is really the first year. It's the year of saying, right, what are we going to do? So we've set out a lovely strategy. What are we actually going to do over the next 12 months to really drive that strategy forward? So it's just giving you that framework and just being really clear that this isn't something we've decided to do. It is a requirement on us, and we're trying to make it work as well as we can for the local population. If you can just click us on the next slide. I'm not going to focus on that, but it's just an image that says these things are all sort of interwoven and connected and in the planning process. So if you can, just skip us on. So as part of this process, we did run a small event pre-Christmas, and we had about 60 attendees. We didn't mass advertise it at that point, just to say, look, these are some of the things we're thinking about. And if it's helpful to the committee, I can share some of those. Our aim after this meeting is to share with you a current draft of what we've got. Now, it's very much a work in progress, but our aim is to say, we'd really value your insight and opinions. But what we don't want to do is go and run a separate engagement process with the population of Wiltshire that is at odds with what's going on in the health and wellbeing strategy. So we're aligning those two things, speaking with David and the team here to say, how do we make sure that if we're going to ask the public a question, let's ask the question once and let's do it in a way that answers both requirements in that sense. But we did run this event pre-Christmas just to get a feel from partners across the system, stakeholders, and some representative people to say, are we in the right ballpark in terms of what we're saying? And as I say, I can touch on a few headlines in a minute. They're not in the slides, but I can touch on them. If you can just click us on the next slide. So this was just about saying, look, these are the types of things we would expect to be in the strategy. So we want to know what evidence base we're basing our strategy on. What's the situation facing the population of BSW? Now, there's a great danger there that we go into a great deal of detail and just replicate what you're saying in the local strategy. So we're going to very much look at the sort of headline messages in that and keep it fairly short and functional. We do want to get into this question of what's important to us. What difference are we as partners trying to make for, to support the population to make, really? And really not drive at, it's very easy for us to think, right, it's all about the elective care services or whatever, but actually what does it sound like when we hear it through the lens of our population? So we're trying to get into that question a bit more as a partnership. I suspect by the end of March, when we produce the first version, we'll have only got so far with that, but we'll get better, and particularly from a health perspective, I think we can learn from the local authorities what you've been doing. We want to really try and get into some of these outcomes. You know, when we stand back in 10 years' time or 5 years' time, what do we think is going to be different for the population? So there was a housing conversation earlier that, that I heard part of. You know, what are we saying about the things that we would like to be different, and trying to word those, you know, through the eyes of the population, rather than us talking about, well, we'd have shorter waiting lists or we'd have whatever. What does it mean to, you know, have a better quality of life? So we're looking at it through that perspective. We're also thinking about some of the principles that hang us together as partners and how we would cooperate. And then really touching on some of the initiatives that we will undertake to make the difference. So that's just a basic structure. As I say, I'll touch on a few of the headlines in a minute. The final point, and this is a really important one for partners, we've been talking for a long time about focusing on inequalities, focusing on how we use our resources, use them in the best way, prevention and well-being. There's a big question in this about us being honest about that and saying, well, this is how we spend our resources today. Where do we expect to be in 5 or 10 years' time? How different do we expect this to be? We are working at that, and it's proving a challenge to put all the information together and really have that conversation. But that's a really important part of this strategy, I think, is to say, let's be honest about whether we are going to change our focus and change the way we spend our money, or are we going to continue to spend it in the way we have? Shall I touch on just some of the headlines that have emerged? Because that's probably the most interesting bit, and then we can just touch on the process. Bear with me 2 secs. I could type. So I'm just going to say these. They won't appear on the screen in front of you. But some of the things that you would expect to hear emerging as what people are telling us is important is, you know, tackling inequality in our health and care system is a big theme that we're hearing from all 3 areas and a priority for us to work on. Very much this emphasis that we focus on the individual and supporting individuals, and not start with the big buildings or the big institutions, but we start with the individual as a concept. The concept of thinking about all ages in life. So, you know, children and young people, it's often said, you know, we don't pay as much attention as perhaps we should, and pay attention there, but also, you know, how people live well and how they age well will be part of that conversation. A focus on prevention and well-being, and really trying to give weight to people like Kate in the back there. You know, are we giving the support and messaging that says, you know, we genuinely want to keep people well rather than pick up the pieces when they become unwell, and what would that look like? I'm not saying any of this is easy, but I'm saying this is a sort of focus for our strategy. We from health, particularly in the conversations we've been having with local authority partners, have, you know, this concept of the wider determinants of health. So, you know, again, you know, we want to make sure that we are paying attention to the condition of our housing and the conditions of that, the diet, the exercise, all those things. I'm really thinking about, have people got good employment and got opportunities? So we want the strategy to be holistic and not focused entirely just on the delivery of services, if I word it that way. A very common theme in all 3 areas is the development of communities and local communities, and making sure that we've got the teams and the support in those local communities to really help them flourish and prosper. And what we do in one area might be different to another area because of the needs of that local population, but that sense that we are paying attention as partners to the way communities develop. And in that, drawing on the strengths of those communities. So we know there's a whole host of assets. We saw it particularly in the COVID pandemic, where voluntary sector and other partners really stepped in, really working with what's there. And then a sort of wrap around to it all, I guess, is the environmental impact that we're having in the way that we deliver all of our services and things. So that's a sort of pick list. And when you see the draft of the strategy, you'll see some of those themes sort of come through. I suppose a couple of areas where I would just draw a distinction between what we might do at the system level and what you'll have locally. When we talk about whole life at the system level, because of some of the services we'll be particularly focused on, we will include a very strong emphasis on making sure our dying well services are in place and what have you. So that's something we very much expect to sort of emphasise and sort of say, have we got a good setup around how we support people to die well? We will talk about the whole care model. So the drafts I've seen of the local strategies are very community focused. They're very much about the sort of local things that get done. Obviously, when we write the system strategy, we'll want to talk about the hospitals. We'll want to talk about some of those big bits about how they function to support what we're doing. So there will be that slightly broader spectrum, I think, in terms of some of that. But again, there will be connections between the two. I think we will talk about some of the ways we are really changing the way the system operates. So, there's a lot of work going on in areas such as trying to put greater diagnostic capability into our communities so that people can access tests and results and things at a more local level. So we will talk about some of the specifics at that scale, as opposed to some of the real community work that will be going on in teams and neighbourhoods in your local strategies. We will talk about, I think, the recruitment, the development of the workforce, and how by working across BSW, we can make all of our organisations more attractive employers, how we can avoid robbing Peter to pay Paul in the recruitment process, which is often the case because, we advertise one job and we pull across. And we can talk about investment in, apprenticeship programmes or whatever across our organisations in a way that really drives things forward. And I think that will, it's not in the current draft, but that by the time we finish will be a key theme. We'll talk about the sort of digital and estates elements and talk about how we make the best use of some of our estate and some of our big estate and those aspects, but also how we do digital. Because, if we're going to have shared information at the fingertips of people who deliver care, we have to do that quite systemically. We can't do it very locally. We have to have some underpinning sort of frameworks and things. So I think that will be an emphasis in there. And then that question about how we're getting the best of our resources, I think that will be another theme that we particularly draw out. So the plan really is to get the first draft, and it is a first draft, out and get people commenting on it and what have you, to link in with your local team that are doing your local health and wellbeing strategy so that they can think about how we do engagement with your population, not to duplicate that engagement, and then really to see what feedback we get and go forward with. The aim, we have to have a document by the end of March 23. It won't be perfect. It will be the first step on the journey. So that's how we're positioning it. But Richard, I know you're involved. I don't know if you'd like to comment.
If I can just comment, and speaking very much as chair of the ICP and not leader of the council here, because this is a strategy that's got to work for the entirety of the BSW area. I think it's been very interesting attending the engagement event just to see quite how many jealously guarded strategies, programs, plans the NHS have, and quite how impossible it is going to be to bring all of those together into a single strategy. This is going to have to be, because if we try, we will create something that is utterly dysfunctional, which might potentially be a way of describing the attempt to merge all of the elements of the NHS together at the moment, and the entire rationale behind the integrated care system is to create that functionality, that sort of core drive inside those disparate groups. It's going to have to be thematic. In the same way that if you look at the Wiltshire Business Plan, we've got our guiding themes. We've discussed that. I've discussed that in some detail with Sue, Stephanie from the ICB, and there's agreement that we really are going to need to look at what the right thematic areas are, and Richard's been mentioning some of them. That early intervention, prevention work, and that tackling inequality really, I think, are the two fundamental ones, but somewhere in there, partnership, and it's going to mean something very different to our understanding of partnership as a council. Not very different, but subtly different enough to be significant. So it's going to be really interesting seeing how we pull that together. And I suspect, given the number of partners involved and given the wide range of views, it's probably going to take a couple of stabs to get drafts down into something that's concise enough to be relevant, broad enough not to make sure that anyone is feeling massively left out. I question, for example, that dying well, whether dying well was really part of the core strategy for the ICB, and had some very, very robust pushback, which was good to get, because that's the only way we're going to make this work. Is, in fact, Gordon, you were there when I was challenging some of it. And the only way we're going to get to a strategy that's really going to work for people is if we do challenge and have those pretty blunt discussions about it. So I think the point about the fact that the first iteration of this is in March is not going to be a final document is really key as well. I would say the same about the council business plan. The delivery of it will need to constantly evolve. I think here we will probably need to see the strategy evolve and the delivery evolve at the same time, over the strategy should evolve less over the course of the first year, but I would expect to see significant changes to the strategy over the course of that first year as we look at how to implement it. The difference in approach between the partners that we've got to bring together in this process, where as councils, the issue of budgeting is we must balance our books and therefore everything is focused around a different approach to budgets. The NHS, that has not been the case, that rigour is being applied. The question of what the ICS as a whole should and shouldn't do is clearly massively important. Then the question of who is responsible, and again, other discussions at the ICB board last week, but other discussions about making sure that we understand who is responsible for an area and that one partner isn't cutting funding, that then means all the other partners suddenly don't have that preventative work going on, or that it's happening in one part of the BSW area and not in others. Honestly, it's a hideous piece of work, but the potential benefit from it is huge. It's going to be incredibly time-consuming and difficult.
Thanks, Richard. Richard, did you have more in the slides, or should we open up for questions?
No, I think probably to make that point that we will get a very rough version of a draft out, because that's where we are in the interplay between the different bits. There's some gaps in there, and we've signposted some of those gaps. And I've been honest about the resourcing bit. We're still pulling that together. But I think if people would like an early sight of it and are comfortable, we'll put it out into the Wiltshire community, and yourselves. But we'll do that in conjunction with the local team. That's the bit I'm really wary of, is that we start sending something out from BSW level that conflicts with what you're doing locally. And we just don't want to do that.
Sure. No, we've got a meeting. Our next meeting is the 28th of February, he says, checking. Yeah, 28th of February. Do you think the draft would be ready by then? Or
so we'll get you a draft out this week, I think,
right.
will be the aim, but treat it as a draft, treat it as a starter of the conversation. What we will do over that month is we'll be getting feedback from other places. We'll be having conversations like this in other rooms, as Richard says. Hideous, was that your word? I might own that. This is a challenge. But yeah, we'll put that out there, and we'd really welcome feedback and thoughts from this committee and others. But what we're not trying to do is push it out to everybody in your community, because we might confuse them. And I think that's the bit we want to just be careful of, and let your local team take the lead on that.
Sure. Okay, great. Thank you, Richard. Any questions from members? Pauline?
Yes, just a quick question, Chair. Thank you. It sounds like this strategy is really necessary, actually. And I just wondered, as it's mandated by the Health and Care Act, whether or not the information is fed up to central government.
I'll speak freely, if I may. This is a point where they've written it into the Act and then said it's the responsibility of the Integrated Care Partnership, and it's very difficult to have anything that governs the partnership because there's no singular route of how it gets reported. So our colleagues at NHS England, for example, have said, well, you can send us a version and we'd love to review it and comment, but we haven't got a statutory role in doing that. So it's one of these things where I'm sure we will be asked to submit it and we'll get some comments. But it really is about us owning it, I think, and saying, do you know what, that's a good reflection for us. But statutorily, it's really hard to say where it goes above an integrated care partnership, because there is no singular body that sits across local authority and health in that way.
I would massively resist NHS England thinking they have any say in it. This is a strategy for Bath, Swindon and Wiltshire. And the moment NHS start trying to control it, we may as well tear it up and ignore it. Really, and you're right, it's absolutely critical to bring together so many disparate partners, to give them that single vision that everyone can get behind, and then start aligning all of their work streams to deliver that vision and nothing else.
I think you can see why this would be useful for central government, this information, because it just brings those partners together in delivering for BSW. So in a way, if you've got every BSW equivalent in the country doing the same thing, well, that information is quite valuable to central government in terms of how they fund us all.
So I think you make a really good point. I am observing in the chains of command above me and up nationally, people struggling to adjust to this new world where partnership working becomes more important. And I think all of this would be learning and information. And as you say, it poses a different question, because if all of them say, we want to pay more attention to resourcing prevention, that itself is information, isn't it? Different to, you know, we must prioritise entirely elective waiting lists. So I think, you know, let's use it in that way. But as Richard says, I think it's not allowing it to be driven by people who might have narrower targets than we do as a set of partners.
Thanks, Pauline, for the question. And any further questions from the committee on this item? No? Okay, right. In which case, I will move a resolution that we note the report on engagement within Wiltshire on the ongoing development of the initial integrated care strategy, and for the chair and vice chair to explore the best approach to further scrutiny engagement on the draft strategy and report back to committee. Could I have a seconder for that? Thank you. Any objections? Okay, that's moved. Thank you, Richard, Fiona and Richard for your input on that item. We will move on then to item number 12, our forward work programme. On page 41 of your agenda packs, we have our forward work programme, which will be updated to reflect the changes we've made today and also discussed at Overview and Scrutiny Management Committee next week. I'd just like to thank our two cabinet members, our directors, and also Fiona Slevin-Brown from the ICB for joining me and Gordon in meetings before Christmas, where we discussed potential work areas for the committee to look at over the next 12 months. Several items have been added to the work programme as a result of this engagement, including items on domestic abuse support, substance abuse support, health coaches, and today's item on the integrated care strategy. I just want to open up to the committee members for any further input. I know Councillor Devendran had a suggestion on dental services, so Monica, if you want to expand on that.
Thank you, Chair. Can we look into the challenges faced by dentists working in the NHS within Wiltshire, please?
I'm sure that's something we could look to add to the forward work programme. We haven't looked at dental services specifically for a number of years now, I believe, so that will be definitely worthwhile. And Jo Cullen did touch on it in her primary care update. So yeah, I think that's absolutely something to add.
Just one more thing.
Okay.
Steps taken to combat the difficulties in obtaining dental appointments within Wiltshire? Can we look into that as well, please?
Absolutely, yeah.
Thank you.
Yeah, we could either have those both on the same agenda, sort of. Yeah.
I think that Healthwatch has done a recent piece of work on access to dental services.
Ah, okay.
I'll get onto the office and get it and forward it.
Lovely. Yeah, great. If you could get that sent on to Henry and Julie, that would be really useful. Thank you. Diane.
I was just wondering whether we could look at, when they produce it, that the dementia care strategy is well overdue. I believe they are just starting to look at it, and I'm wondering if we can actually have that brought back to us to look at having, so we can look at it.
Yeah, sure. Henry, Julie, are you happy to make some inquiries on that? And we can then gauge how best to integrate that into the work programme. Cool. Well, indeed, yes, yeah. Yeah. So again, something we'd like to see a draft stage rather than a final stage. Indeed. Yeah, so we can have meaningful input. Yeah. Agreed. Any other suggestions or proposals for work items? And I think we've some very good suggestions there, so thank you for those. Great. Okay, in which case I'll just move that we note the committee's forward work programme with the addition of a future item on dental services in Wiltshire and also on the forthcoming draft dementia care strategy. Can I have a seconder for that proposal, please? Gordon, thank you. And I'm assuming there's no objections, but I better ask. No objections. Great. Thank you. Okay, yes. And so I'll just move on to item 13, urgent items. We've no urgent items, but I would like to introduce Julie, who's a senior scrutiny officer who's going to be supporting our work going forward and already has been considerable support, including producing the report on the inquiry session that we're planning. So thank you, Julie, for that. And it's great to have you on board with the committee. And then I'll move on to item 14, date of next meeting, which is, as alluded to earlier, on the 28th of February, 2023. I think we're back here in the Kennet Room, and it's at 10:30 a.m. So look forward to seeing you all then. At 10:30 till nowish. Yes. Great. Thank you all for attending this morning. Well, you know, good point, Pip, actually. Yes, we did remind councillors earlier, but again, just to emphasise the importance of our input on the budget scrutiny and the session tomorrow afternoon, which is a team session, as I said earlier, online session, 2 p.m. Tomorrow, Thursday. So see you all then as well. Anyone who is unable to attend, please do submit questions by email. Okay, thank you all. See you tomorrow and or February.